Good morning.
Good morning.
Thank you all for joining us today for our first Congressional Black Maternal Health Caucus Stakeholder Summit. You are so important. You are the stakeholders. I do want to thank all of my colleagues who are here today for all of their dedicated efforts around the issue of maternal health outcomes for Black women in America. I am thrilled to see so many of our advocates here today. It is my pleasure to greet you from the more than 700,000 residents of the 12th Congressional District in North Carolina, Charlotte, Mecklenburg. The work of every stakeholder in this room is incredibly important, and we all know that we're facing a Black maternal health crisis in this country. And that's why Congresswoman Underwood and I started the Black Maternal Health Caucus, which it's bipartisan. We now have 75 members strong. Yeah, we all about that. So the caucus aims to raise awareness about this public health crisis, to educate other members of Congress, and to identify legislative solutions to improve maternal health outcomes. But we cannot do it alone, and we know we can't do it alone. And that's why it's meaningful that we're all here today, that you're here, and that members of Congress, staff, other stakeholders need to hear from you about the incredible work that your organizations are doing to end racial disparities in maternal health and to improve outcomes for women of color. We need your recommendations on what we as a caucus and a Congress can do to address the bias and the racism in the healthcare system and to increase access to quality health care for Black women. Together, we can amplify the voices and the needs of mothers and families all across the nation. Together, we can make sure that all mothers have the right, the respect, and the resources that they need to thrive and survive before, during, and after pregnancy. So again, I want to thank everyone for coming out today, and we look forward to hearing your invaluable insights and your expertise and all the things that you're doing to help close the gaps. And now it is my pleasure to introduce my co-chair, the distinguished lady from Illinois, Representative Laura Underwood.
Thank you.
Sorry, I keep mispronouncing her. It's Lauren
Yes, ma'am.
Underwood.
Thank
All right.
you.
I'm a teacher. I wanted to go back and correct myself. Thank you.
Thank you so much. Good morning. Oh, I'm so excited about this day. Thank you, Congresswoman Adams, for your leadership and your partnership on this critically important issue. Thank you to my colleagues who are going to be joining us throughout the morning today for all of their leadership and their commitment to finding solutions. And thank you all to our advocates, to our experts who have joined us in the room and online today. Your daily work helps improve the outcomes for women and infants throughout the country, and what you do is so critical to ending this crisis. And hello to all of our friends on Facebook Live. It's working. I'm so proud of what the House has done already this year. We have made some real strides, real achievements, especially in passing the Labor HHS Appropriations Bill that includes critical funding for maternal health disparities research at the National Institutes of Health and a $12 million increase for the Centers for Disease Control's Maternity and Mortality Review Committee's program. $12 million. So excited. Hi, sir. But we have a lot more work to do to solve the Black maternal mortality crisis in our country. You all have incredible insights to share with us, and I'm grateful that you're here today to help inform the work of this caucus. We look forward to hearing from you on a few things: the work that your organizations are engaged on, policy issues that the caucus should focus on, and your views on what members of Congress need to understand about Black maternal health. I'm confident with the Congress now elevating your work and supporting evidence-based, culturally competent best practices, we will truly be able to reverse current trends and achieve optimal birth outcomes for more Black women and their families across the country. Again, thank you. I'm so glad you're here today. I look forward to continuing to work together to end this crisis. Thank you. Now, we have been joined by the majority leader in these House of Representatives, and I'm so grateful to have his support on this issue. I'd like to bring up and welcome Leader Steny Hoyer.
Boy, oh boy, are moms and babies very lucky to have Alma Adams and Lauren Underwood in their corner, pumping this issue, focusing us on this issue, and fighting for them. Lauren and Alma just went out the door, but this lady comes to a lot of my meetings.
I do.
And I will tell you, there is nobody in Congress who is more inclined to speak up, speak out, and speak truth. I don't know that I have any power, but speak truth, period. And Lauren, thank you very much. What an asset you are to the Congress of the United States. Thank you very much. Now I have on my list two people with whom I've worked a very, very long time to acknowledge, and I don't see either of them here, but we are extraordinarily fortunate in this last election to elect as a brand new member of Congress somebody who is the most experienced member perhaps in the Congress of the United States, Donna Shalala, the former Secretary of Health and Human Services, President of University of Wisconsin, President of the University of Miami, President of the Clinton Foundation, President of the world. But nobody knows more about this issue than she does. And we are so lucky to have her with us. And then, of course, the giant of the Congress, John Lewis, who is also very focused on this issue, as he has been for years in making sure people were treated equally. I want to thank all of them for helping to raise awareness and to convene this summit on the disparities facing African American mothers and mothers-to-be and seek solutions. I had the opportunity to serve on the Labor, Health, Human Services, and Education Appropriations Subcommittee for 23 years, starting in 1983. And I served with some extraordinary people on that subcommittee. And very early on, one of the things that we raised, Congressman Lou Stokes, some of you, you're all too young to, maybe not all of us, too young to remember Lou Stokes, but he was a giant, an African-American. His brother was the mayor of their town, and he and I served on the Labor Health Committee together. And in 1983, we were questioning the director of NIH, and we were talking about the studies that they were doing, intramural, extramural, and we were talking about the cohorts of people who were participating in these basic research programs. And we were struck by the extraordinary absence of people of color and women from the cohorts. There were more men in the breast cancer cohorts than there were women. We started to get that changed. We still need to be focused on that, by the way, here 30 years later. I'm proud to be a founding member of the Black Maternal Health Caucus. African American women are nearly 4 times more likely. You know these statistics, but they bear repeating because they're so dramatic. 4 times more likely and more than twice as likely as women of other races to die from preventable pregnancy-related complications. And Congress has a role to play in addressing this challenge. The tragedy is that should not happen in this country. We have the expertise, the medical skills, the prescription drugs to prevent that happening. It's one thing when something happens and you can't prevent it. It's another thing when it happens and you know, had you been conscious of the issue and employed the resources necessary, the loss would not have occurred. This is an issue I care very deeply about, which is of critical importance for the communities I represent. According to the Centers for Disease Control and Prevention and the Prince George's County Health Department, Prince George's County, as some of you know, is the county that abuts the District of Columbia on the east. As a matter of fact, if the state of Maryland hadn't given the District of Columbia to the nation, it would be in Maryland. But Prince George's County is just over the D.C. border. According to the Center for Disease Control and, as I said, Prince George's County, over the last decade, the maternal mortality rate for African American women in Prince George's County, Maryland, by the way, one of the richest counties in America. Now, we don't hear that we're the richest county in America, because we live between Fairfax County and Montgomery County in Maryland, who are the sort of, I guess, Jeff Bezos and somebody else who's rich. But I don't want to make an analogy to any one of the counties of that particular individual. But Prince George's County, in my district, was higher than the average rate across Maryland. Why? Because we have a high minority population. As a majority leader, I'm committed to making this issue a priority for the House to reduce these disparities and working with Representatives Adams and Representative Underwood, Shalala, and others to make sure Congress is doing its job to help. And by the way, we passed through the House of Representatives a appropriation bill for NIH and for HHS and Department of Education, the best bill that has ever been passed through this House of Representatives. Thank you for your help in making us to do that. Talk to the United States Senate. My friend Chairman Blunt likes that bill. Hopefully his party will allow him to move that bill. This needs to be a partnership between the federal government, the states, and local communities to ensure that every mother has access to the best prenatal delivery and postnatal care available, no matter her background or her income level. I love the statement of the United Negro College Fund. A mind is a terrible thing to waste. Ladies and gentlemen, we don't have a person to waste in America. We need every one of our very special resources, our children. Whatever their color, whatever their nationality, whatever their religion, we need every one of them. And the tragedy of losing them when it was not defensible in the United States of America must stop. We're here today because we recognize that something big needs to be done to address this challenge and are determined with you to get it done. I want to thank all the organizations represented here for the important work that you've been doing so far and for sharing the stories of your successes and, yes, of your failures, the tragedies that have occurred. We need to touch people's minds and touch their hearts and say this ought not to happen in America. I thank you for your commitment to the noble cause and to make this an all-hands-on-deck effort, which it needs to be, and I look forward to working with you, my colleagues, and our community to make sure that this tragic loss does not continue to occur. We can do it. We must do it. And as John Lewis would tell us all, keep our eye on the prize. God bless you. Thank you very much.
Thank you, Mr. Leader. We are now joined by two incredibly distinguished members of the House, Congresswoman Robin Kelly and Congresswoman Brenda Lawrence. They are each going to join us. I would like to turn it over to my colleague, Congresswoman Robin Kelly from Illinois, who has been leading on maternal health disparities and a range of healthcare issues for years as the chair of the Congressional Black Caucus's Health Brain Trust. Congresswoman Kelly. Thank you.
Good morning, everyone. Thank you, Lauren. Thank you to Congresswoman Adams, who had to run and chair her committee, and Congresswoman Underwood for convening us all here today to discuss the alarming phenomenon that is dying while becoming a mother, particularly a Black mother, as you've heard. As you will hear from the experts in this room today, most with whom my office has worked with over the past 2 years, so thank you very much, to build strong legislation to combat this critical issue. 700 to 900 American mothers die every year. More than in any other developed nation, women in the United States stand the risk of death during their pregnancies and childbirth. America is the only developed nation where the rates of women dying during childbirth is 26.7 mothers per 100,000 births, and it's rising. Black and Native American mothers die due to birthing complications at higher rates than any other mothers. They are 300 to 400% more likely to die from childbirth or pregnancy-related complications than white mothers. and I was with OB-GYNs, and in the state of Washington, Native moms died 8 times the rate, and where Congresswoman Underwood and I represent is 6-1 for Black mothers. Mothers like Kyra Johnson, the daughter-in-law of Judge Glenda Hatchett, a mother who raced cars, flew planes, spoke 5 languages, still died soon after giving birth to her second son, Langston. Mothers like Dr. Shalone Irving, a lieutenant commander in the Public Health Services Corps and a graduate school classmate of Congresswoman Underwood, was an epidemiologist who dedicated her career to studying the stresses associated with racism. She died only weeks after giving birth to her daughter. Preventable conditions such as hemorrhaging, preeclampsia, and other acute conditions stunted this bright life and that of others. And I just have to interject this. We were talking about this, and I believe, I'm trying to remember if it was Oversight, I was running around so much, or ENC, and someone actually made a comment, one of my colleagues, that talked about maybe it's not access to care, but maybe we're eating too much fried chicken. They actually said that. It's on the record. That's why things were happening. So I assured him it wasn't that. So what we do as members of Congress, as providers, advocates, many of us mothers and all of us children of mothers, what do we do to address this issue? As I mentioned, for the last 2 years, I have had the pleasure of working alongside many of you in this room to put forth a legislative remedy to protect the health of women who desire to become mamas. The Mama Act, H.R. 1897, is a comprehensive bill that tackles the growing epidemic of maternal mortality and severe morbidity in 6 ways, dealing with data collection and standardization, authorizing evidence-based emergency obstetrical practices, expanding care coverage through a mama's full postpartum period, uplifting culturally competent care across the healthcare delivery continuum, supporting maternal mortality review committees, and publishing best practices through designated federal agencies. To learn more about the Mama Act or to support it if you're not already a co-sponsor, please grab one of these. I have it right here. Dear colleague letters, or contact my health policy advisor, Mia Keys, who many of you know. Some of my colleagues are also doing great work in the maternal health space, as evidenced today. These efforts are strong, and I believe we together can change the cost of maternal care inside and outside of clinical settings. Too many mamas have already died. Too many kids are already growing up without a mother. Too many families are living a nightmare that doesn't end. As chairwoman of the Congressional Black Caucus Health Brain Trust, which Louis Stokes started, and co-chair of the Congressional Caucus on Black Women and Girls, of prime importance to me is equitable health care, access, and delivery. I look forward to continuously working to uplift the major women's health issue that is maternal death and near death. Thank you so much, and thank you, Lauren, and thank Alma.
Yes, thank you. Thank you, Congresswoman Kelly. We have been joined by Congresswoman Brenda Lawrence. Now, Congresswoman Lawrence represents Southfield, Michigan, and some other areas outside of Detroit, but she also serves as the chair of the Democratic Women's Caucus and the co-chair of the Bipartisan Women's Caucus here in the House. And so she brings tremendous expertise to our group, and I'd like to invite her up.
I want to say good morning to all the women and the men who are in this room. I want to thank the amazing leadership of my colleague, Congresswoman Underwood. I'm here today, you've heard all the statistics, and I really am preaching to the choir. So this is what I just want to do, a call to action. So often, when I bring up the issue of maternal mortality, people are like, really? Is that happening? Is America really the highest in maternal mortality in the world of any developing country? They seem shocked. So the call to action today is that we are going to have to amplify our voices and our efforts. You know, attending a funeral and shedding a tear, was that life in vain if we are not doing the work and making sure it doesn't happen again? Being a chair of the Women's Caucus and knowing how important it is for women, and yes, a few good men, to stand up and fight for those issues that are so often left on the ground or on the table, because you know the theory is if it's a woman, you can handle it, you'll get over it, you'll shed a tear, and then you'll just stand up and keep it moving, because that's what we do. We are the strongest, and I tell women to own this. We are the nurturers of this country. We are the ones who stand up and we take care of our children. We are the number one caregivers in this country. We are the number one educators. If you've been educated in America, women have educated you. When you talk about who stands up, you know, they always talk about Rosie the Riveter. Guess what? The men left, nothing stopped because the women stepped up and kept this country whole while we were at war. There's example of women standing up in leadership. And I'm just going to give you this as a sense of empowerment today, because this is not a happy subject. It's a subject that we need to get to work on. Women, every time they try to capture the soul or the moral values of this country, they do it in an image of a woman. Think about criminal justice or justice in America, which is the third leg of our democracy, our executive branch, our legislative, and our judicial. It chose a woman, and she's blindfolded, she's holding the scales. When they talk about this issue that we're fighting over today, immigration, inclusion, and who we are, bring me your poor. A woman stands with a light saying, come into our country, we welcome you. And on top of this building that we're sitting in, the Capitol of the United States, there's a woman. Her title is Lady Freedom. She was cast by a slave. She sat on top of this building before women even got the right to vote. She has a sword in one hand and the wreath of peace in the other. See, what's so powerful about that is that you know that if you come after our children, our family, and our community, we will fight you. We will use the sword of faith, of truth, and of love, and we will fight you on those issues. And then we also fight, we know peace is the way. So isn't it ironic that this place that was ran by men, there's a woman who was cast to capture who we are in this place of democracy. Women, we have now controlled the outcomes of elections. I'm sitting in Congress because women came out to vote for me. 60% of the win that I got came from women. We have changed the demographics and the conversation. And so women, as I sit here and have the humble role of leading in this Congress as a representative of women in Congress, the highest we've ever had, the most diverse we've ever had, I'm saying to everyone in here, we cannot do this alone. Every single one of you, we need you engaged in doing what you do. Bring your brilliance, bring your compassion, bring your strength, bring your fight, because this must stop in America. We cannot continue to just report and talk about what's happening. We're going to have to change this. I'm on board. Thank you so much. Let's get to work. Thank you.
Thank you, Congresswoman Lawrence. We've been joined by Congresswoman Ilhan Omar from Minnesota. We have so many distinguished members of the House of Representatives, bipartisan members, as part of our caucus. And so you're going to see many of them join us throughout the day. They're going to stay for as long as they can. But I know that we came to hear from, yes, some of our great colleagues in the House, but also this compilation of experts and advocates and stakeholders and those who do this work each and every day in each of our communities. And so we have a standing room crowd here. We have a few seats sprinkled around, so I'm going to invite folks to sit in those seats as we bring up Dr. Jamila Taylor. So Dr. Taylor is from the Center for American Progress, and she's going to kick us off this morning. Many of you know Dr. Taylor quite well because she's been leading the policy efforts to address maternal health disparities for years. And I'll be in and out. Congresswoman Adams will be in and out, but we leave you in very, very good hands right now. Dr. Taylor. Thank you. Turn on your...
Thank you, Representative Underwood. Good morning, everyone. So I have the pleasure of starting the conversation off today before my illustrious colleagues get to also weigh in on this important issue. So speaking on behalf of the Center for American Progress, which is a political organization and think tank based here in Washington, D.C., our approach to addressing maternal and infant health disparities really focuses on grounding policy solutions in a framing of structural racism. According to the Aspen Institute, structural racism is a system where public policies, institutional practices, and cultural representations work to reinforce and perpetuate structural inequity. Structural racism is fueled by predominantly white power structures that perpetuate power imbalances among people of color. Therefore, in order for policy solutions to address maternal and infant mortality adequately, they must be grounded in social justice frameworks that intentionally designed to address these power imbalances. So the Center for American Progress developed a comprehensive policy blueprint to address these issues. And actually, we were a little bit bold in terms of our approach. We actually claim that these solutions will eliminate racial disparities in maternal and infant mortality. So I'm just going to go over those really briefly. I know we don't have a lot of time, and I want to make sure that I have time for my colleagues to also weigh in today. So our policy blueprint would do 5 things. The first is improve access to critical services. Despite the promise of programs like the Affordable Care Act, Medicaid, and the Children's Health Insurance Program, women and infants still lack access to care that keep them healthy. In addition to protecting and strengthening these programs against harmful restrictions, policymakers must augment screening and treatment for women at risk for preterm birth, ensure that all women have access to quality maternity care no matter where they live, support access to comprehensive reproductive health care, including access to abortion, provide tools to families to help them navigate health settings, like access to midwives and doulas who help to advocate for families through pregnancy, labor, and delivery. The second thing the blueprint would do is improve the quality of care provided to pregnant women. Simply spending more on maternity care will not improve outcomes for women and infants. Instead, policymakers must improve the quality of care. This requires addressing racism in healthcare through training and recruiting of a diverse, compassionate workforce, developing standardized evidence-based guidelines for care and assessments for mothers and infants, and adopting new models of care that improve families' experiences by linking payment to quality. The third thing it would do is address maternal and infant mental health. Mental health challenges are linked to risk factors for maternal and infant mortality. And too often, maternal and infant mental health problems go unrecognized and unaddressed, particularly for families of color. And this has devastating consequences. To address this, policymakers must identify barriers in access to mental health care, dismantle those barriers, including things like reducing high out-of-pocket costs and the lack of available providers, and then also making sure that screening is available for both moms and infants. The fourth thing is enhanced supports for families before and after birth. And here, we focus on the fact that all families deserve to thrive, but not all have the opportunity to do so. Adjusting to parenthood can be difficult, particularly for families that are experiencing economic insecurity. So supporting things like access to housing, clean water, and food are all important in terms of addressing this issue. And I should also add there are a number of community-based organizations that are already doing this important work to co-locate the services that family needs, and you'll hear more about that today. And last but not least, improve data collection and oversight. I think we want to commend the House and the Senate for passing the Preventing Maternal Deaths Act last Congress, which was amazing. At the same time, more work needs to be done. We need to build off of that win. We need to collect and disseminate reliable data for maternal and infant mortality, as well as focusing on how that data can support the solutions. We need to make sure that maternal mortality review committees are diverse, including in terms of stakeholders, as well as representation of people most heavily impacted by this issue. So with that, I'm going to stop there and pass it on to my colleagues. Thank you for having me today, and I look forward to the discussion.
Thank you. I'm Andrea Harris. I'm Chief of Staff to Congresswoman Lauren Underwood. Really pleased to be here, and we'll turn it over to Elizabeth Gay from the Black Mamas Matter Alliance.
Good morning. My name is Elizabeth Dawes-Gay, and I'm co-director of the Black Mamas Matter Alliance. I want to start by saying thank you to Congresswoman Adams and Congresswoman Underwood for creating this important caucus and providing us with the opportunity to share our work and recommendations through this summit. We're grateful for your leadership and dedication to solving the maternal mortality and morbidity crisis. Black Mamas Matter Alliance is the premier national multidisciplinary network of Black women-led organizations and professionals working to advance Black maternal health, rights, and justice. We work to ensure that policy is grounded in the human rights, reproductive justice, and birth justice frameworks, and that it addresses racial inequities to improve Black maternal health outcomes. And I want to note that we define Black mamas as representing the full diversity of our lived experiences, which includes birthing persons such as cis Black women, trans folks, and gender nonconforming individuals. Additionally, the term Black mamas includes all people of African descent, such as Afro-Latinx, African American, Afro-Caribbean, Black and African immigrants living in the United States. The Black Mamas Matter Alliance leverages the talent and knowledge that exists in our community and cultivates innovative research methods to inform the policy agenda to improve Black maternal health. We seek to enhance care for Black mamas through holistic and comprehensive approaches and care models. And one of our greatest accomplishments to date has been to shift the narrative about Black mamas from one of individual blame to focus on the structural and social inequities that exacerbate maternal health disparities. We have successfully amplified Black-led approaches to maternity care. We've amplified the voices of Black mamas, as well as the need to decolonize care, research, and policy, and disrupt negative narratives about Black motherhood. BMMA is the founder of critical national initiatives such as Black Maternal Health Week and the Black Maternal Health Conference and Training Institute. So I also want to thank Congresswoman Adams for introducing the very first resolution to recognize Black Maternal Health Week nationally in 2018. We're so grateful for her support and her ongoing commitment to Black-led health initiatives. The Black Mamas Matter Alliance serves as a national voice and coordinating entity for stakeholders working to change what's happening with Black mamas in this country. We are an alliance of over 60 organizations and individuals, including care providers such as physicians, midwives, doulas, and perinatal health workers. We are researchers, policy and public health professionals, lawyers, and advocates. Some of the organizations you'll hear from today, such as Sister Song, the National Birth Equity Collaborative, Mama Toto Village, Ancient Song Doula Services, the National Perinatal Task Force, and the Black Women's Health Imperative, are kindred partners of the Alliance. And we're also joined by individual collaborators like Dr. Taylor, Nia Mitchell, and Ebony Marcel. BMMA intentionally centers Black women's experiences, voices, and leadership in all of the work that we do. This is reflected in our motto: listen to Black women, trust Black women, invest in Black women. Those words are not just our motto, but they serve as a guide for those who are sincere in their commitment to improve Black maternal health experiences and outcomes. If there's one message we want members of Congress to leave with today, it's that the answers to this important problem lie within the Black community. The most effective policies will be those that are informed and implemented by members of the communities that are most affected. We call on members of Congress and the members of this caucus, as leaders who have demonstrated their commitment to advancing Black maternal health rights and justice, to give their time and attention to the Alliance's collaborators and kindred partners. We ask you to seek counsel from and listen to those Black women-led organizations who have the lived experiences, evidence, and community connections to know what the best solutions are. They know what works and what saves lives. That's why the very first recommendation in our policy agenda, which I have here, there are copies in the back and you can also find online. Our very first priority is to prioritize the leadership of Black women in the development and implementation of policies and programs that are intended to affect the Black community. In the agenda, we also call on policymakers to name and address the racism, discrimination, mistreatment, and neglect of Black women that happens within the American healthcare system. And we also call on members of Congress to continue to fight to protect and expand financial access to the full range of reproductive and maternal health services, from contraception to abortion to prenatal and postpartum care. We know that restrictions on reproductive health hurt women of color the most. But we also know that strong and strategic policy can help fix that. In closing, we encourage you to visit our website, blackmamasmatter.org, to read our policy agenda and learn more about the work that our members are doing. The Black Mamas Matter Alliance is here to support you however we can and connect the caucus to Black experts, problem solvers, and leaders who can join you as thought partners. Thank you again to the Black Maternal Health Caucus and its fearless leaders. And we're hopeful that this caucus will help create the change that Black mamas need. Thank you.
Hi, everyone. My name is Keishelle Webster. I am Congresswoman Adams' healthcare legislative assistant, and we're just so grateful that you all could join us today. And thank you, Elizabeth. It's my pleasure to introduce Tammy Boyd. She is the Director of Health Policy and Legislative Affairs at the Black Women's Health Imperative.
Thank you. Good morning. Let me first say thank you to Congresswoman Underwood and Congresswoman Adams for their leadership in forming the Black Maternal Health Caucus and for hosting today's summit. My name is Tammy Boyd, and as you mentioned, I'm the Director of Health Policy at Black Women's Health Imperative. We are a national organization dedicated to improving the health and wellness of our nation's 21 million Black women and girls, physically, emotionally, and financially. For 36 years, we have advocated for policies to help ensure that women of color can live healthy lives and achieve health equity. Through investments in evidence-based strategies, we deliver bold new programs and advocate health-promoting policies. As we know, Black women are 3 to 4 times more likely than white women to die from complications related to pregnancy and childbirth. There are high-profile examples such as tennis icon Serena Williams, Kira Johnson, daughter-in-law of Judge Hatchett, that place Black maternal health in the spotlight, but it is also a reality for Black women all over the country. The crisis of maternal mortality for Black women persists across economic, educational, and geographic boundaries. Most profound are economic inequalities that impact the ability of African American women and their families to not only support themselves, but also secure sufficient health care. Black Women's Health Imperative recommends a multifaceted legislative and policy approach to address the maternal mortality crisis. Comprehensive maternal mortality legislation should include addressing implicit bias in provider care and systems of care delivery, improve access to quality care, addressing social determinants of health, and providing greater economic security to improve Black maternal health outcomes. Although Black women are disproportionately impacted by risk factors related to pregnancy, such as hypertension or gestational diabetes, these potential complications are made worse by the compounded stress of racial discrimination and lower quality health care, which research has shown to lead to adverse birth and maternal outcomes. Black Women's Health Imperative is recommending a deeper analysis of data of the lived experiences of pregnant Black women. That data would inform a national strategy to examine the underlying causes of poor maternal outcomes among Black women and develop and implement strategies for policy practice and delivery to make significant improvement. And because we know that change comes through both practice and policy, we at Black Women's Health Imperative are addressing Black maternal health in 5 ways. First, Black Women's Health Imperative released a national policy agenda entitled Black Women Vote, a National Health Policy Agenda. The agenda outlines key legislation and policy priorities on Black women's health, including recommendations to protect Black women during prenatal care, labor and delivery, and postpartum care. And if anyone, we have some copies as well if folks would like to. Secondly, we are partnering with MedShare to launch a campaign to increase the visibility of maternal health deserts in rural Georgia. Thirdly, we partnered with Healthy Birthday, the 501c3 nonprofit organization that created Count the Kicks app, to share important information on pregnancy with the goal of improving birth outcomes for families of color. Fourth, Black Women's Health Imperative will soon release a Black Women's Birth Plan that will be available for digital download from Black Women's Health Imperative's website. We are also hosting a conversation series on Black women's health called Real Talk, Real Women. The purpose is to educate and empower Black women to hold their elected officials accountable on key health issues impacting Black women, such as Black maternal health. It is never going to be enough to just point out the issues as we understand them, so we must continue to have collective conversations such as this summit. We look forward to furthering this conversation and working with the Black Maternal Health Caucus members and staff as they draft and shepherd legislation into law. Thank you again to Representatives Adams and Underwood for your leadership on addressing Black maternal health.
Next, we have Nadia Hussein from Moms Rising. She is the Maternal Justice Campaign Director.
Hello, everybody. Good morning. And thank you, firstly, to Representative Adams and Representative Underwood for not only their leadership, but their initiative to really start this, to create this caucus and bring us all together today. Moms Rising is a national organization of over 1 million members that organizes and advocates around issues that impact mothers, children, and families. Our Maternal Justice Campaign works on grassroots organizing and advancing policy efforts to address the maternal mortality morbidity issues in our country, concentrating on the disparities Black people who give birth face. As many of our speakers have shared about the racial disparities, these facts have gone unchanged for decades and generation, and also these disparities are independent of age, parity, or education. Over the last 3 years, Moms Rising has focused on uplifting Black maternal health, mortality, and morbidity via advocacy, education, and mobilization efforts. We've supported and continue to support legislation on both the state and federal levels that specifically address racial disparities in maternal mortality and morbidity, legislation such as the CARE Act, the Moms Act, and Mommies Act in Congress, amongst others, as well as state legislation such as the Dignity in Pregnancy and Childbirth Act in California, and legislative efforts in New Jersey to expand Medicaid and expand doula care access, among other strategies. Tens of thousands of our members have signed onto petitions supporting policies that would improve Black maternal health. We have delivered those signatures to Congress to urge them to work to save the lives of Black people giving birth. And if you go in the back, we have a fact sheet. These are an example of some of what we give to Congress to educate our members. Our Moms Rising members have taken 22 actions, reached out to media, leaders, public and private health organizations, and local, state, and national policymakers to share their stories and demand change. You can go to our website, momsrising.org, to access the storybook and see stories from almost every state. We published 2 national birthing storybooks. We've utilized monthly #maternal justice Twitter chats and our weekly radio show to educate, engage, and raise awareness around maternal health, focusing on Black maternal health. The chats have reached millions of accounts and have had hundreds and millions of impressions. We have created digital content, such as Now This videos, reaching over 1 million views, and Facebook Lives with the media company The Root. The recommendations to the caucus that Moms Rising would like to put forth are as follows. Focus on prioritizing the protection and expansion of healthcare access. 60% of maternal deaths would be avoided with better healthcare access. Make evidence-based birthing protocols mandatory in hospitals. Defend against any attacks on the Affordable Health Care Act. This includes protecting, defending, and expanding Medicaid to before birth and after birth to at least a year. Expand Medicaid coverage or reimbursement for doulas and midwives with fair compensation for their services. Take a strong stance on advocating for protecting and expanding abortion for all people who need it. And we also stand beside all of the recommendations given by the organizations here today. Our recommendations to Congress include listening to Black people giving birth and recognize that they are the experts on their bodies and their experiences when it comes to their reproductive choices, pregnancy and birth process and postpartum period. Understanding the importance of centering Black people in any and all efforts relating to addressing maternal mortality and morbidity. supporting and expanding access to reproductive health choices, and protecting and expanding abortion access for all people that need them. And lastly, but most importantly, understanding and recognizing that naming racism and implicit bias explicitly as part of the problem of maternal health disparities in our nation is key to addressing the issues we have been brought together to speak about today. We cannot begin to address a problem until we name it and recognize it for what it is. Thank you.
Having mic issues today. Thank you, Nadia. Next, we'll hear from Jessica Pinckney, who's the Vice President of Government Affairs at In Our Own Voice.
Good morning, everyone. As was said, I'm Jessica Pinckney with In Our Own Voice, the National Black Women's Reproductive Justice Agenda. And I first want to extend a great thanks to Congresswoman Adams and Congresswoman Underwood, not only for convening this summit today, but also for starting this amazing caucus. A wonderful group of people who we're really excited to work with on this incredibly important issue. To start, In Our Own Voice is a national state partnership with 7 Black-led reproductive justice organizations in California, Texas, Tennessee, Georgia, Ohio, Pennsylvania, and Louisiana, and includes our national partner, Black Women's Health Imperative, as well. The goal of our organization is to lift up the voices of Black women, girls, and femmes, not only at the state level in the states in which we work, but also here at the national level. And we do this work through a reproductive justice framework, which I will get into a little bit. In terms of Black maternal health, where In Our Own Voice really stands is that Black women deserve the right to accessible, safe, and competent maternal health care that supports healthy pregnancies and births and that provides access to affordable, quality health care that protects from unnecessary complications or potential death. This principle is at the core of the reproductive justice framework, which is the human right to control one's body, sexuality, gender, and reproductive choices. And we know that reproductive justice will only be achieved when all women, girls, and femmes have the complete economic, social, and political power and resources to make healthy decisions about our bodies, our lives, our families, and our communities. As it relates to the work that In Our Own Voice has done around Black maternal health, we've really been working to lift up Black maternal health as a reproductive justice issue. We never want to talk about Black maternal health without centering bodily autonomy and the ability to choose if, when, and how to parent. We're also always explicit that implicit bias, racism, and discrimination are at the core of the maternal mortality crisis in this country. Additionally, as was just mentioned, we've been working to draw the linkage between abortion restrictions and maternal mortality because we know that states with more abortion restrictions also have higher rates of maternal mortality. And as the reproductive justice framework tells us, women of color, Black women, do not live monolithic lives, and we cannot separate our experiences in the healthcare system or elsewhere. As Brenda Lawrence mentioned, as Congresswoman Lawrence mentioned, it's really important to amplify and educate as it relates to this issue. There are a lot of misconceptions as it relates to Black maternal mortality, and we've been thrilled to be able to co-host some events. One with Mission Partners in May called Hear Her, a call to action on maternal mortality, which was a public education and call to action event with both a federal and state focus. Many of my colleagues around the table were able to share about their experiences in various healthcare settings around Black maternal health. This event was really geared at elevating Black women's voices around what's currently working, what's not working, and what's needed to make change. And I think I really lift that up to reiterate what my colleagues around the table have said about listening and hearing from Black women, those who are at the core of the work and those who are experiencing this crisis firsthand. Additionally, we're really excited, in conjunction with Black Women's Health Imperative, to be hosting in August as well with Black Women's Blueprint, a sexual abuse organization, a roundtable on sexual abuse to maternal mortality pipeline, really aimed at unifying sexual assault and reproductive justice advocates. And again, I lift this up because the intersectionality component of this work is incredibly important to In Our Own Voice and incredibly important to ensuring that we're centering the whole individual and their full range of lived experiences. Lastly, I'll say that In Our Own Voice has been advocating in Congress for legislation that both lifts up the existing racial health disparities in maternal health care and is aimed at reducing such racial disparities. And we're thrilled to support some of the legislation that has been mentioned here today. In terms of Congresswoman Underwood's call to help provide recommendations to the caucus, I'll lift up just a few. One, improving access and quality of healthcare coverage, including coverage of services provided by community health workers, doulas, and other community-based healthcare providers. Two, addressing underlying social determinants of health. Three, prioritizing social supports for Black women and communities. Four, addressing intersectional issues impacting maternal health care, including but certainly not limited to nutrition and food security, adequate safe housing and safe communities, as well as healthy occupational and environmental conditions. Five, improvements to the healthcare worker pipeline, specifically focused on diversity. And six, as was just mentioned, there are significant improvements to abortion access necessary in this country to ensure that Black women, women of color, all individuals who want to access abortion care have that ability, and so that they do not have to end up facing a maternal mortality crisis later on in pregnancy if they choose. Lastly, in terms of things we think are incredibly important for members of Congress to understand when addressing the Black maternal health crisis, the maternal mortality issues that exist in this country are a systemic problem. It will require breaking down systems that are in place and rebuilding in many instances, and it most certainly requires an intersectional lens. Thank you.
Thank you, Jessica. We appreciate that. And next we have Aza from Mama Toto Village. She's the executive director at that center. So take it away.
Greetings, members of the Black Maternal Health Caucus. I would first like to thank you for affording me the opportunity to speak before you today. My name is Aza Nadari. I'm a licensed certified professional midwife, a doctoral student, and a trained family therapist, and I'm the co-founder and executive director of Mama Toto Village. Mama Toto is a nonprofit devoted to creating pathways for women of color in the field of public health and human services and providing accessible perinatal support designed to empower women with the tools to make informed decisions in their maternity care, parenting, and lives. Mama Toto's theory of change is grounded in a 3 generations approach, which we define as an upstream solution that recognizes the impacts of racism on the multi-generational transmission of health, well-being, parenting behaviors, and wealth. It emphasizes the need to consider the intersection of social and structural determinants to facilitate a progression of the family towards wellness as a biological and social norm. Mama Toto's programs exist along 2 domains, service delivery and workforce. Our home visiting program uses the evidence-based screening tools and interventions that was designed for and by Black women. The program delivers care during the perinatal period up to 3 to 6 months postpartum in the form of care coordination, system navigation, perinatal mental health assessments, labor support, and intensive postpartum. This program is funded in part through contracts with Medicaid managed care organizations in the district. We also have a perinatal health worker training program, which is a two-year workforce program based upon a community health worker model that prepares women in the communities that we serve to be paraprofessionals while offering low-resource and single parenting persons equitable pay and transferable job skills. Our trainees have leveraged these opportunities and pursued education in family medicine, obstetrics, midwifery, both the certified nurse midwifery and CPM pathways, social work, and lactation. It is racism, not race, that has forged the path to where we are in our present-day maternal health crisis. The fierce urgency of now demands a metamorphosis. It requires that we show up differently, with new ideas, with new energy, and with an unwavering and collective commitment to equity, justice, and upholding human rights for Black people. I believe that the caucus must consider solutions that expand beyond the episode of pregnancy and consider the biological precipitators of adverse perinatal experiences. Holistic models that target improving psychosocial supports, increase quality surveillance for high acuity pregnancies and complicated births, and expanded postpartum care is necessary. Additional concrete solutions are considerations for alternative payment models to include capitated rate and bundle payments and tying quality to care, as Dr. Taylor mentioned, and outcomes to reimbursement and incentives. Recognition of certified professional midwives. As of April 2019, 33 states licensed certified professional midwives, and only 14 of these states reimburse CPMs as providers in their state Medicaid plans. This will allow for CPMs to be included in the system of care and reimbursement. It will also allow participation for CPMs in the federal student loan repayment program, which then supports the increase of the critical racial representation of CPMs in the workforce. Black women and people of color only make up 2% of the total midwifery workforce in the United States, and that includes certified professional midwives, certified nurse midwives, and certified midwives. It will also open access to participation in the National Health Corps and allow CPMs to directly participate in federally qualified health centers, which are sustainable models for serving Medicaid populations. Additional recommendations are enhanced oversight of the inspection process and government-funded housing. I believe that oversight in this area is sorely lacking, resulting in families being forced to reside in environmental conditions that by any standard would be deemed unacceptable and uninhabitable. State investment in emergency housing for pregnant women who are homeless, including those who are partnered, investment in growing a community health worker workforce as a pathway to mitigating healthcare shortages and diversifying the field, revising postpartum care policies to establish follow-up within the first 2 weeks and ongoing surveillance as a norm and not an exception. And lastly, investment in inpatient perinatal psychiatric facilities that support the mother-baby dyad, as well as training on perinatal mood and anxiety disorders, as an inclusion in all counseling, obstetrical, and pediatric programs. This includes midwifery, as well as training on the appropriate assessments and instruments. Thank you.
Thank you for those recommendations. As a reminder to speakers, we have 32 people speaking today, which we're so excited about, but that means that we have very limited time. We have the room until just after 1. So if you could keep your remarks to 3 minutes, I think that would help us hear from everyone. Next, we have Jen Holcomb, the Director of U.S. Policy and Advocacy for 1,000 Days.
Thank you so much for including 1,000 Days in today's summit. Thank you to Representative Adams and Underwood, along with Kelly, Lawrence, so many of other congressional leaders who both were here today but who couldn't be here, who are tremendous champions for maternal health, especially Black maternal health. It's really exciting to see Congress actually take this seriously for maybe the first time. I'm Jen Holcomb. I am the Director of Policy and Advocacy for the U.S. side of our work at 1,000 Days. We're a relatively new organization, especially on the domestic side, and so much of what we bring to this table is echoing the voices of everyone else. And I will keep my remarks short because we don't need to hear the same thing over and over again. That being said, 1,000 Days is fighting for the strongest start for all moms and babies. We do so because the 1,000-day window between a woman's pregnancy and her child's second birthday is a time of tremendous opportunity, but also potential. What happens in those 1,000 days, including the experiences of moms, whether it's through their healthcare experiences or their life experiences, sets the trajectory for a child's future development and their future health. But with that, the future health and development of entire countries, communities, and societies. For us at 1,000 Days, we believe that 2 things should guide our policy priorities: the science and the experience of moms and their families. It's through that lens that I offer some suggestions to what has already been said. But first, I want to thank the amazing women who are here today who have been leading on these efforts for years, if not decades. Thank you for your work, thank you for your voice, and thank you for all you have done for moms, especially Black women. There is no doubt that the way that Black women are treated in our healthcare system is different than white women. It's unacceptable and it must change. We see it in the research on health outcomes, but we also hear it in the stories women tell us over and over again. Breaking down these systemic structures and biases will take an all-hands-on-deck approach. I know that what has been said today does not need to be repeated, but I will say this. We agree with much of what has been said. The stakes are simply too high to not do all we can to improve the health of Black moms. We need to increase the number of providers who are women of color within all specialties. We need to ensure the voices and decisions of Black women are not just heard, but they're respected. Ensure that care is patient-centered, respectful, and responsive to the needs of Black women. Expand access to all health services, mental, physical, but also improve the quality of those services. We need to invest in Black maternal health and ensure that those investments are going to things that actually will improve the healthcare of moms, whether it's by hospitals, midwife practices, OBGYNs, community health centers, family practice doctors, mental health professionals, or others who can demonstrate an impact. But we also need to call out the systemic changes that have to take place at every level and in every community. The one thing that I do want to add to today's discussion is the need for paid leave and its impact on Black moms, but all women's ability to both take care of themselves during pregnancy, take care of their child after childbirth, but also just recover from childbirth. Access to paid leave provides women with this time to not only care for their child, but themselves. Yet, because it's largely up to the discretion of employers, women, especially Black and Hispanic women, are not likely to have access to this critical benefit. And in fact, we call it a benefit instead of a necessity. Far too often, a mother's physical and mental health and her recovery is sidelined when a new baby arrives. But as a recent study found, childbirth is equal to running a marathon on a woman's body. And the evidence is clear. When women have access to paid leave, they have better outcomes. Many of the things that we've talked about today, we believe could be improved or at least partially addressed with access to paid leave for Black women and all women. Reduced pregnancy complications, reduced risk of postpartum depression and other mental health conditions, improved breastfeeding rates that improve women's health, but the list goes on, and we know that her baby's health can benefit too from paid leave. When we look at the disparities in maternal health, we can't not talk about paid leave and its impact. Thank you again for this opportunity. Thank you to Representative Adams and Underwood for starting this caucus and making sure this conversation is happening in the halls of our Capitol. And thank you for everyone else for your leadership on this issue. 1,000 Days stands ready to help however we can to provide the voices, to lift up the voices, to lift up the solutions, and to lift up the work that's being done by so many great organizations within this community. Thank you.
Thank you, Jen, for your comments. We appreciate. Next, we have Heather Clark from the National Association to Advance Black Birth. Heather, take it away.
Thank you very much. And I, like so many, want to thank Representative Adams and Underwood and all of our esteemed speakers and audience who's here. This is truly just amazing that there's so much emphasis on this very, very critical problem. So the National Association to Advance Black Birth is a reform of the International Confederation of Traditional Child Birth Workers, who are continuing that work. And we're particularly interested in, as many of you are, the state of maternal health. We are in the midst of developing a Black Women and Persons Bill of Rights. And what we want to include in that Bill of Rights is taking a broader look at the problem. And for us, that means looking at some of the root causes of maternal death and morbidity, because we know that for every one woman who dies, There are many, many more that suffer severe morbidity. And that also includes looking at transgenerational trauma. We have research to show that someone's health can be impacted by events that took place 4 generations ago, but we don't know how far back, and there's a lot of support to believe that the transatlantic slave trade still impacts Black women and persons today. So we have to look at that. We have to look at the trauma, which is further advanced with current states of racism, implicit bias, all the things that have been mentioned. And that trauma, of course, is impacted by the environment. So epigenetics comes into play. And all of this impacts maternal health. And we also feel that it's important to, in looking at maternal health, to address that before a woman gets pregnant. Working with the CDC's preconception work group panel, they make it real clear that the way to impact both infant and maternal health is begin before she gets pregnant. So that means, as mentioned here before, that women need to have access to comprehensive reproductive health care that provides her with all options of contraception and abortion, and also addressing trauma and identifying existing medical and psychological issues that can impact her health. NAB is also looking at reproductive justice, and with our Bill of Rights, we particularly want to focus on lack of access to care. So again, going back to making sure that there's coverage for preconception care and primary care before a woman even gets pregnant. It's almost too late. With all of the stuff that Black women bring to the pregnancy, it's almost too late to begin to prevent death or severe morbidity if we start when she's pregnant and even in the first trimester, and unfortunately we don't get them in the first trimester. Pregnancy intention, we discovered on the preconception work group panel, is one of the top 3 indicators for good outcomes. So we really need to work with women to help them get to a state of optimum health before they get pregnant, and then plan in wholesome ways. So looking at other things that we want to focus on is support and finances, as well as, I mentioned, access. In many of our communities, hospitals and clinics are closing. There's very little access to contraceptive care, primary care, preconception, as I mentioned. With many of our support institutions, family, churches, schools, extended families breaking down, there's a significant lack of acts of support. As a midwife for over 40 years, it really hurt my heart to see how alone and unsupported and depressed many Black women were during the pregnancy because they just didn't have that support. And of course, we need caring, sensitive, culturally competent providers. And finally, finances. Lots of work in public health. One of the big issues is housing, affordable housing for Black women and children, which again add to the stress and compound health problems and that can be exacerbated with the event of birth. So recommendations that we would like to offer are creating community empowerment zones, perhaps looking at zip codes and parts of the country where significant funding can be poured into that community on many levels, not just in healthcare, but supporting local businesses to support women, and also including law enforcement in the community empowerment zone, so that within that community, there are multiple sources to support the woman's needs, whatever they are. More home visitation programs. not just for first-time moms, but for moms who have multiple children and have multiple stresses. As many has mentioned before, supported more monies for doulas, community health workers, midwifery model, and wraparound services, and with free access. And I'm going to let Jenny Joseph speak to the importance of getting women in without that block of, okay, show your card and it needs to be active today. Parental leave, I'm so glad you mentioned that. Evidence shows how important parental leave is for improving outcomes, and that should be for partners as well as women. And on the side of partners, maternal death is not just a woman issue, it's a community issue. And when so many of their partners are in jail for minor offenses, they lack that support that can really, really make a difference. So we need to address issues in the prison reform system also. I've mentioned preconception health care and interconceptual care and coverage for that. Financial, we need to pay women. You know, why do we wait until the baby's born and start giving her money? We need to pay her during the pregnancy so that she can afford somewhere to live. She can afford decent food and transportation. In the recent Strong Start program, birth centers were paid $500 per pregnant woman. Why can't we give pregnant women $500 per month during their pregnancy to help offset stress? I'm almost done. So I think the biggest thing that I would like Congress to understand, and somebody mentioned this already, we know within our communities what we need. We have many, many experts and people in our communities to support women and provide care for them. But we need the resources to do that. And the money, those resources need to be given to the communities, to the monies, and not big hospitals where the money goes to executive salaries and big pharmaceutical companies. Thank you.
Thank you, Heather. And next, we've got Jenny Alscher from the Center for Reproductive Rights. She is actually just back from maternity leave, so she's been through this. But she's the Federal Policy Counsel there. So Jenny, take it away.
Thank you. Good morning, everyone. My name is Jennifer Jacoby Alscher, and I am an attorney and a Federal Policy Counsel, as Cashel said, at the Center for Reproductive Rights. We were thrilled to help launch the Black Maternal Health Caucus in April, and we thank the Congresswomen and this caucus for considering our recommendations today. So since 1992, the Center for Reproductive Rights has used the power of law and policy to expand access to reproductive health care around the nation and the world. Last year, we launched our U.S. Maternal Health and Rights Initiative, which promotes the rights of pregnant, birthing, and postpartum people in the U.S. and seeks to improve access to safe and respectful care for all who need it. Working in partnership with organizations and communities that are directly impacted by birth inequities, we provide advocates with human rights-based legal and policy resources, collaborative engagement with international human rights mechanisms, and technical assistance on maternal health law and policy at the local, state, and federal level. So Cashel just mentioned that I came back from maternity leave this week, so I have to be honest with you all. I must have changed my remarks 20 times, and I think it's in part due to that and coming back after 4 months. But I was speaking to my dad this morning, and he's an old New York City progressive, just for background, and I still ask his advice on everything, even as a new mom, right? And, you know, I told my dad, I said, there's nothing that I can really say today that my esteemed colleagues won't already say. We all know the problem, he told me. And he said, maybe, you know, is there something that we can do now, that Congress can do right now? And maybe if we work together to do that, we can save even just one life. So I took my dad's advice and focused on what the caucus can do today. So this goes without saying that we recommend that you continue to discuss the central role of race in this crisis in any briefings or legislation that comes out of this. There's an undeniable interest in maternal health legislation from lawmakers. We've seen it year after year now. But many are still uncomfortable talking about race and racial bias. That has to change because that's the crux of the issue, as you heard from our colleagues today. So to amplify this issue, members of this caucus might request reports on racial disparities in maternal health care from federal agencies like HHS and NIH. Or seek a GAO report on this issue in the Medicaid context. So recently, this past spring, while I was out, GAO issued, they released an issue brief that mentioned race maybe at the very bottom, and it was in reference to an example in Wisconsin. I believe it was a medical home example. But they can go much further and investigate this issue. And if we do that, perhaps in addition to this, caucus members might also encourage committees to hold more hearings on racial disparities in maternal health care. But as we heard from Representative Kelly, there have been, some, we need to find a way to make this meaningful because we heard some insensitive remarks or remarks that are not based on evidence. So we have to figure out a way how to make those hearings actually really valuable. So through all that fact-finding, reporting, briefings, committee hearings, making sure that members push that. Congress can craft even better legislation. What we have is great, but maybe if we work together and focus on maybe one or two narrow issues and concrete solutions, whether it be Medicaid, implicit bias training, or improving the postpartum visit, we can save just one life. So let's do this now. We also recommend that any caucus briefings or legislation focus on subsets of the Black population that are particularly vulnerable to being left behind. So this includes, but is not limited to, Black women in jails and prisons, Black people capable of pregnancy that do not identify as women, as Elizabeth said, Black women in the military, Black women who live in rural areas. So partnership with communities that are directly impacted and are the experts on their experiences is critical to do that. So I want to leave you all with this. Members of Congress should understand that this crisis is real. It is a human rights concern. It's not just a public health issue. And sadly, it is part of so many of our own personal journeys through motherhood. Just 4 months ago, I experienced this firsthand. 2 care providers failed to believe me when I told them that something didn't feel right in the 38th week of my pregnancy with my daughter. I had developed preeclampsia, and my baby was born with a low birth weight. And 31 years earlier, as of yesterday, my mother, a Black woman from New York City, experienced the same treatment during her pregnancy with me, and she almost died. So the Center for Reproductive Rights looks forward to supporting you and developing concrete solutions now to help break this cycle. Thank you so much for your time.
Thank you very much. We'll next hear from Liz McCammon, staff attorney at the National Health Law Program.
Hi, I'm Liz McCammon, a staff attorney at the National Health Law Program. It's a public interest law firm founded in 1969. Thank you to the caucus for the opportunity to share with you today. And many of my remarks will echo the policy suggestions of my colleagues. So the National Health Law Program believes that one of the key things the caucus can do is to help expand access to doula care for Black women in a way that is inclusive, equitable, and sustainable. The caucus can work to ensure that coverage for doula care is fully inclusive of Black-led community-based doula groups, as well as other traditional and community-based workers and birth practices, and that reimbursement for doula care provide a fair and living wage. One obvious category of Black women that could benefit from an expansion of doula care is low-income Black women on Medicaid. Currently, most doulas are paid by their clients out of pocket, with the average cost hovering around $1,200. Virtually no private health plans cover doulas, and currently there are only 2 existing programs in the states for Medicaid reimbursement of doulas in Oregon and Minnesota, although we know interest is growing nationwide. So in this vein, in May of this year, the National Health Law Program formally launched our Doula Medicaid project, which seeks to ensure that all pregnant individuals who are enrolled in the Medicaid program who want access to a doula can have one. We have compiled resources on federal and state legislation, fact sheets, issue briefs, and more, which can be found on our website at healthlaw.org/doula Medicaid project. And I've also brought copies of 2 of our fact sheets, which are available in the back of the room. We also know that so many of the health conditions and diagnoses that result in Black maternal mortality and morbidity arise within 1 year postpartum. Thus, the caucus can have a tremendous impact by continuing to work with us to expand Medicaid postpartum coverage from the current 60 days to the full year following the end of pregnancy. And finally, it is critical in this work that patients be trusted to make their own healthcare decisions and that their autonomy is fully respected. We have a horrific history in our country of forcing certain populations of women, including Black women, to be sterilized or to use certain family planning methods. And we don't think that it's a coincidence that the states with the highest restrictions on abortion access are also the states with the highest levels of maternal mortality and morbidity, especially for women of color. We encourage the caucus to work with all of us here on defending and advancing access to the full range of reproductive health services in the Medicaid program and beyond, free from coercion, discrimination, and stigma. Thank you.
Thank you. Next, we have Doriana Mason from the National Women's Law Center.
Thank you. I'm so happy to be here. Again, my name is Dorianne Mason from the National Women's Law Center, and I serve as the Director of Health Equity, which is a new position. The National Women's Law Center is a nonprofit public interest law firm, and we use the tools of the law and policy to reduce or eliminate the harms that come to women. So through our work, we have very specifically and intentionally worked to increase access to Medicaid. So when I think about Black maternal health, I can think about what does that woman's coverage look like? What does that woman's care when they're seeking out services look like? And what does the community in which she lives look like? Is that community equitable? Is that community just? And those are all the factors that lead into what that woman's experience looks like. And so when we're working at the Center on Black maternal health, we are thinking very intentionally about intersectionality. So you can't talk about maternal health without talking about food access. You can't talk about maternal health without talking about what the criminal justice system looks like. You can't talk about maternal health without talking about environmental justice. You can't talk about maternal health without talking about many other areas that impact that woman's life. And so when I think about the work that we're doing, and when I think about the work that Congress can do, it's really taking a look at all of those issues that impact that woman's experience. And so we know, and it's been said many times around this table, that those experiences are a direct result of systemic racism, right? They're a result of sexism. They're a result of implicit bias. And those are, disparities that are deeply entrenched in our systems, deeply entrenched in many of our psyches. And so what I hope to do at the National Women's Law Center through this position is to really help to liberate Black women, right? So to help us to be able to eliminate these barriers and these institutional issues that impact Black maternal morbidity and mortality. So I want to thank Congresswoman Adams and Congresswoman Underwood, and I look forward to the work that we're going to be able to do together that really addresses all of those intersectional issues through policy that impact Black women's morbidity. Thank you.
Thank you, Dorianne. Next, we have Mimi Spalding from Planned Parenthood.
Yes, good morning. My name is Mimi Spalding, and I'm a senior policy analyst on Medicaid issues at Planned Parenthood Federation of America. We really appreciate being invited and also the Congresswomen's leadership in this space. As one of the nation's leading providers for sexual and reproductive health care, Planned Parenthood knows that we play a critical role in not only delivering quality, affordable, and compassionate care to over over 2.4 million people across the country in need of our services. But we also it is incumbent upon us to serve as an advocate for our patients. We serve over 2.4 million patients at over 600 health centers across the United States, and we are so proud to be working alongside reproductive justice partners, other providers in the caucus to address this crisis. At Planned Parenthood, our affiliates are really on the front lines, and we at PPFA are attacking this crisis from all angles in support of Black women. So whether that's through advocacy, education, research, or care provision, we know that we have to center Black women in the care that we provide to Black women to properly assess the root causes of maternal death and bring about actionable change. Not only are our affiliates advocating at their state legislatures for things like Medicaid expansion or stopping harmful threats to Medicaid, such as work requirements or waiving presumptive eligibility, et cetera. Our affiliates are also working within their roles as trusted community-based providers to knock down barriers to accessing care. Among some of the services that some of our affiliates provide are prenatal care, primary care, and care coordination, and we often serve as a warm handoff to community-based partners. At Planned Parenthood, we come to our patients and meet them where they are across the lifespan. So we also provide, of course, abortion and contraception and STI testing and treatment. Our health centers are essential or participating in programs at state level to more closely and comprehensively deliver essential services directly to our patients through things like home visitation and even telemedicine. So take one of our affiliates in Ohio, for example, who has served more than 200 Black women and their families through their participation in the state's Healthy Moms, Healthy Babies program. Through care coordination and home visitation, this affiliate has been able to make a significant impact in their community, which has for years had some of the highest rates of maternal and infant mortality in the United States. We would also be remiss if we didn't mention our ardent support behind the leadership of reproductive justice partners who have been on the front lines. So our goal is really to help uplift the important and vital work that RJ partners are doing to raise awareness and demand that our healthcare system not only listens to Black women, but is spurred to action by centering the healthcare needs of Black women, which comes first and foremost to improving health outcomes. Some of our recommendations, of course, have been mentioned throughout this panel. I particularly love Aza's recommendations. I think that we at Planned Parenthood think that expanding and developing the workforce and making deeper investments into the workforce, including diversity in the workforce and training for midwives, as Aza mentioned, et cetera, we think that's very important. And also ensuring that Black women are able to access culturally sensitive, compassionate care no matter where they turn to for their healthcare needs. As others mentioned, implicit bias training also needs to be a part of the permanent infrastructure of healthcare delivery, reform, and system change. And secondly, we also encourage the caucus to think about creative ways to address the social determinants of health and address barriers so that women can make it to regular appointments, including transportation barriers, childcare needs, paid family leave, food security, and other social factors. One thing in the Medicaid space, or a couple things in the Medicaid space, is that there have been threats to things like non-emergency medical transportation. So we encourage the caucus and other members to really be vigilant in monitoring those threats. And also, just finally, Medicaid reimbursement issues are really a social justice issue. If providers are not reimbursed at a rate that is equitable and allows them to keep their doors open, then women and patients and communities suffer. So finally, I want to close by sharing a quote from one of our patient advocates and volunteers from Baltimore who shared her story, her birth story, in a blog for Black Maternal Health Week in 2019. The patient said that when she went to the hospital, they didn't take time to ask about my situation or experiences. They took one look at me and wrote my story themselves. That's not how healthcare should work. So again, Planned Parenthood stands with our partners and with the caucus, and we are committed to really thinking through positive policy change to reverse this unconscionable crisis in our country. Thank you so much.
Thank you, Mimi. We've been joined by Congressman Stephen Horsford of Nevada. If he'd like to come in and take just a couple of minutes to give some remarks. Hi, welcome, Congressman.
Good morning. Thank you all for being here. It's great to join with all of you today. First, I want to thank Representative Lauren Underwood and Representative Alma Adams for their leadership on co-chairing this very important caucus. I'm Stephen Horsford from Nevada's 4th Congressional District, and I want to thank our wonderful panelists and all of you who have chosen careers in the healthcare profession, devoting your lives to helping others and using your expertise to raise up this tragic issue and educate all of us on how we can better develop policy to address these shortcomings. I'm here because I want to learn. I want to take some of the best practices from other communities and bring them to my home state of Nevada. That's why I'm a proud member of the Black Maternal Health Caucus. As a caucus, we are dedicated to improving Black maternal health outcomes in the United States, which are some of the worst in the world, with 40 mothers dying every 100,000 births. That's twice the national average and well above most developed countries. Sadly, the United States is the only country in the developed world with an increasing infant mortality rate. Just as sad, Black women are nearly 4 times more likely than white women and more than twice as likely as women of other races to die from preventable pregnancy-related complications. And from 2008 to 2014, Black women were the only ethnic group in Nevada that didn't meet widely used maternal health targets. This is a crisis, and it's a crisis that we must act upon. Now, I am happy to report that in Nevada, our state legislature acted recently to stem the crisis. Last month, the state legislature passed Assemblywoman Danielle Monroe-Moreno's bill to help Nevada get crucial federal dollars for data collection and other steps to reduce pregnancy-related deaths. And in early May, our Governor Sisolak, signed that legislation into law, taking the first step to give Nevada the necessary resources to address this crisis. We lose far too many mothers to preventable deaths. As a husband, as a father of 3 young children, as someone who has sat by my wife's side going through challenging pregnancies, I know how hard this can be for families. But please know that I will continue the fight here in Congress to pass bills like the one we modeled in Nevada at the national level. And I want to welcome the opportunity to be here today and to hear from all of you about your health priorities and how to empower nurses and other healthcare professionals to better serve the American people. Thank you for inviting me here today, and thank you to our panel.
Next, we'll hear from Amy Haddad.
Hi. Thank you again to Congresswoman Adams and Underwood for the invitation, and especially their staff. I know how much hard work goes into this, and I'm going to go off script for a moment to thank you, Congressman, for your remarks, and just really reflecting the importance of federal and state partnerships in getting this passed. Nevada, I think, was really able to push through their legislation to authorize their Maternal Mortality Review Committee because Congress had authorized the fund and appropriated the funding following Preventing Maternal Deaths Act, and they wouldn't be able to apply for it if they didn't pass this legislation. So you can really see how it has that direct impact. The Association of Maternal and Child Health Programs, or AMCHIP as we're called, is a nonprofit organization based here in Washington, D.C., though our core members are leaders and staff from state and territorial public health agencies who manage and implement programs to protect and improve the health of women, children, and families in their respective states. These maternal and child health, or MCH, programs are funded in part by the Title V MCH Services Block Grant, an over 80-year federal-state partnership administered by the Maternal and Child Health Bureau at HRSA. Our other members include academics, health professionals, and family leaders. To touch on just some of our work, AMCHIP is a leader in a number of initiatives aimed at improving maternal and infant health outcomes, efforts that are all centered in a culture of equity. As a core collaborator, along with CDC and Merck for Mothers in the Building U.S. Capacity to Review and Prevent Maternal Deaths program, AMCHIP co-developed and hosts the Review to Action website. It's an online resource to help states assist them in conducting maternal mortality review. It's publicly accessible. It includes templates for reviews, tools for data analysis, components of important legal authorities and protections, and maternal mortality review committee reports from various states. We're also an executive team member in the Alliance for Innovation on Maternal Health, or AIM, also funded by HRSA, led by ACOG. As part of this work, we have been heavily involved in the development of and piloting a bundle related to reducing racial and ethnic disparities. We are the convener of the Infant Mortality Collaborative Improvement and Innovation Network to address social determinants of health. It's another HRSA-funded initiative, and its overarching goal is to create systems change that will directly impact social determinants of health affecting women and men of childbearing age. We're working intensively with 13 states as they develop policies to achieve these goals, including a team from Illinois who are looking at addressing child care for the other children of pregnant women during prenatal appointments, during labor and delivery, and the North Carolina team, which is looking at how they assess health equity impact and implement trainings on health equity. On the policy government affairs side of things, AMCHIP is proud to have worked tirelessly and in collaboration, probably with everyone around this room, on passing legislation and advocating for greater funding for federal programs that are working to improve maternal health. We emphasize the achievement of equity for Black maternal health, provide TA to congressional offices, help draft language for bills and letters, just assist you in any way we can. We have endorsed several pieces of legislation that seek to improve maternal health outcomes, most of the ones that have been mentioned already, including intensive work last year on passing the Preventing Maternal Deaths Act. And as with our programmatic work, we ensure that all efforts keep achievement of equity at the forefront. In order to do this, we recommend that the caucus lift up the work being done at the community level to improve maternal health, especially for Black women in the U.S. We must listen to those with lived experience by highlighting the stories, experiences, and solutions developed by Black women and Black people who birth. The disparities that exist in the U.S. around Black maternal health are rooted in our history of structural racism, strategic disempowerment, and lack of investment in communities of color. Given the impact of this history and the weight of the problem, there is no single solution. Our ability to make progress will require multi-sector collaboration by public health, clinicians, perinatal health workers, community organizations, and more. So as the caucus develops its agenda for the coming months and prioritizes what other members of Congress need to know, we encourage reinforcing that this multi-sector solution must include concurrently improving Medicaid coverage, improving provider education, mitigating and intervening in social risk factors and their disproportionate distribution. We stand ready to help you in any way we can and look forward to continued partnership to achieve our shared goal of equity for Black maternal health in America. Thank you.
Thank you, Amy. I want to acknowledge Congresswoman Donna Shalala and Congresswoman Yvette Clarke for joining. Thank you. So glad to have you here. And next we'll hear from Justine Handelman of Blue Cross Blue Shield Association.
Thank you all for having me here today, and thank you, Congressmen and Congresswomen, for joining in your leadership in this very important issue. I'm honored and humbled to be sitting around a table with some amazing women and amazing organizations that are doing such important things to address this issue. And in particular, to thank the leadership of Congresswoman Underwood and Adams to really lead this call to action and all of those members that have joined this caucus. I'm pleased to be here on behalf of the Blue Cross Blue Shield Association and the 36 independent Blue Cross Blue Shield plans across the U.S. They are in every market and every zip code. And we feel strongly that everyone, no matter who they are or where they live, deserve access to high-quality, affordable health care. And we work day in and day out to make sure that that happens, but we have work to do. We are also committed to addressing the health disparities and social determinants that are contributing to maternal mortality and morbidity among Black women. BCBSA is uniquely positioned in the plans in our system, given their local presence, to collectively share best practices of what's working, to undertake research to find out why these issues exist, and to help inform the national conversation that is so needed. And again, thank you for doing this, because we do need meaningful solutions, and we've heard many today. I just want to highlight a couple of quick examples and then get to some recommendations. Blue plans, and we have more information on the back table with additional, but Blue Cross Blue Shield of Illinois has programs specifically geared toward pregnant women, new mothers and infants, providing the member with education and the support needed throughout the pregnancy, including postpartum, which is so important. They also make sure that obstetrical nurses are assigned to help those with complications during their pregnancy so that people get the right care, the right setting at the right time. In Mississippi, a state with one of the highest maternal mortality rates in the country, Blue Cross Blue Shield of Mississippi is working with the Mississippi Perinatal Quality Collaborative to facilitate simulation-based hands-on training to professionals so they can better identify early on when there are complications, to make sure that they can address those and get positive outcomes. And just quickly, in Tennessee, Blue Cross Blue Shield of Tennessee has established an extensive network of telemedicine to make sure that those, especially in rural communities, have access to specialty care for women at high risk. As we look to what can be done, Jennifer, I love the idea of the studies where we get actionable information, and we have, as an insurer to 1 in 3 Americans, great data. We will soon be releasing a Health of America report that focuses on maternal mortality, and we hope that can inform the conversation. As you look to studies, I'd point out looking at geographic variation is very important, because we know there are different impacts that we have to understand. We must incentivize and encourage the use of platforms that promote better communication across providers, the real-time sharing of information, providers, payers, community-based organizations, so that people have the information to make the best decisions in timely manners. And then ensuring, I believe, Mimi, you mentioned that non-emergency medical transportation remains a mandatory benefit in Medicaid, so that pregnant women can get to care both before birth and after. And then importantly, things that could be done right now, making sure, as I said at the top end, that everyone has access to high quality, affordable care. We've made great strides. We have 90% of people that are covered today, but we still have 10% of Americans that are uninsured. How we get them through the door. Importantly, education, outreach, and enrollment funding. I know there's a bill in Congress. 2/3 of people that are uninsured today are eligible for Medicaid or tax credits under the ACA, making sure they know and we get them in, so critically important. And finally, I'd say we also have to address the underinsured, and it's particularly for impacts disproportionately people, Hispanics and Black populations. We need to make sure that people can access care outside their deductible and not stay home when they should be seeking care because they're sick, they have a sick child, or they feel something is not right. So making sure that there is more care outside the deductible. I'll stop there. There have been many of great things, but thank you again. I see you, Congresswoman Underwood. Thank you again for your leadership here.
Hear from Tatiana Calderon of ACOG.
Hi, thank you for the opportunity to speak with you today. My name is Tatiana Calderon, and I'm with the American College of Obstetricians and Gynecologists. We are grateful to the chairs and members of this caucus for including us today and for lending your voices to this important work. We appreciate the initiative many of you have already taken to reduce and end racial disparities in maternal mortality and look forward to partnering with you. ACOG, which has 58,000 members, is the leading physician organization dedicated to advancing women's health. Key to that mission is our core value that all women should have access to affordable, high quality, and safe health care. So I'd like to highlight several initiatives that ACOG is working on as part of our commitment to addressing implicit bias and increasing culturally competent care. While all of these initiatives share the goal of improving maternal health outcomes, we think it's important for the caucus to be aware of three that specifically focus on Black maternal health. The first is the Alliance for Innovation on Maternal Health, or the AIM program, which, as Amy said, is funded through a cooperative agreement with HRSA and ACOG, with the goal of eliminating preventable maternal mortality in every U.S. birthing facility. This is a voluntary program that promotes safe maternal care through evidence-based best practices, including reduction of racial and ethnic disparities. Currently, there are almost 30 states enrolled in AIM, representing over 2/3 of all U.S. births. The second is a partnership with equity and quality care collaboratives to incorporate patient voices and lived experiences in our patient safety work. As many have already said, Black women's feedback must be a driver for quality improvement measures. The third is Action for Safe Maternity Care Initiative, which aims to empower and equip Black mothers to obtain respectful, person-centered care. As the caucus determines its policy priorities, we recommend prioritizing the following proposals, which are quickly becoming recurring themes in federal legislation. The first is addressing implicit bias and increasing the provision of culturally competent care via support for regional centers of excellence and implicit bias training. The second is authorizing the AIM program to expand the program from the current 30 states to all 50 states and cover all U.S. births. The third is supporting state perinatal quality collaboratives, which are the implementation arm of maternal mortality review committees and key partners to the AIM program in the states. And the fourth is supporting extending Medicaid coverage for mothers to 12 months postpartum from the current requirement of about 60 days postpartum, which would be an important step in keeping at-risk mothers in the health system, considering nearly half of births in the U.S. are covered by the Medicaid program. This change would put mothers' coverage on par with babies who, under current federal law, receive coverage for their first year. Your handout from ACOG titled Momnibus lists bills that have been introduced this Congress that we're supportive of that address these recommendations. Thank you again for this opportunity. We encourage you to use ACOG as a resource, and we look forward to partnering with you on evidence-based policies to end this crisis.
Thank you, Tatiana. Next, we'll hear from Jenny Joseph of Common Sense Childbirth.
Thank you. Thank you very much, Black Maternal Health Caucus, for this opportunity and for this work. I'm Jenny Joseph. I'm a British-trained midwife and the founder and executive director of Common Sense Childbirth, Inc., which is a non-profit corporation of 20 years standing. Our mission is to inspire change in maternal child health systems, to re-empower the birthing mother, father, family, and community by supporting the providers, practitioners, and agencies that are charged with their care. We believe that all women deserve a healthy pregnancy, birth, and baby as a human right. The National Perinatal Task Force is the organizing arm of Common Sense Childbirth and refines our mission by bringing a strong focus on eliminating racial disparities, particularly in Black women, babies, and families. We started in 1998 by providing midwifery services for clients who wanted a home birth. Today, we operate a maternity medical home in Central Florida, serving around 1,000 people a year, providing trauma-informed, culturally safe prenatal and postpartum clinics with a choice of hospital or birth center delivery with midwives, nurse practitioners, or doctors run in English, Spanish, and Portuguese. We also train midwives, doulas, and childbirth professionals in my customized model, the JJ Way. We reached the government's Healthy People 2010 goal of eliminating health disparities in 2006, when we showed a 0% prematurity rate among the African American and Latina women in our first study. And that was compared to a 20% Black prematurity rate for our county and state at that time. Our 2014 and 2016 studies again replicated these outcomes and proved that we were well ahead of the government's ambitious Healthy People 2020 goal of achieving health equity. It's 2019. How close are we to achieving equity? We urged the Black Maternal Health Caucus to set healthy Black women goals every 10 years, starting in 2020, to make achieving health equity a reality. 3 objectives. 1, access to safety. Let's ensure access to and investment in community-based and Black-led organizations, providers, and advocates offering culturally safe health navigation, health education, health literacy, psychosocial support, and integrated community resources and referrals for communities of need. 2, access to quality clinical and behavioral health care. Let's deploy professional and paraprofessional perinatal teams to urban and rural areas of critical maternal health care shortage to establish maternity medical homes or clinics, level 1 birthing facilities run by midwives, and interdisciplinary telemedicine and telehealth collaboration and support services. 3, workforce development. Let's align investment in human resources for a healthcare workforce, keeping the current and future needs of the population and healthcare systems in mind, and support programs to diversify, strengthen, and build a pipeline to perinatal health service careers, while creating access through training to entry-level jobs and entrepreneurial opportunities in marginalized communities. Please understand that across this nation and in areas that I call maternotoxic zones, Black moms are suffering, scared that due to lack of access to safe care, that their lives are at risk, their babies are born too soon, and their future health and well-being is jeopardized. Serena Williams' story supports what countless women have been saying and experiencing for decades. This is not a new crisis. That due to racism, classism, sexism, and institutional and personal biases, Black women are treated differently, not listened to, not believed, and certainly not trusted. We can do better. We must do better. It's time. Thank you.
Thank you. That concludes group 1. So we'll take about 5 minutes to transition to our next group of speakers. Thank you.
You did? Okay. On your phone?
All right, if everyone could please take their seats, we'll get started.
Hi, are we next to each other? Perfect.
All right, thank you for that very efficient transition. We will get started with group 2 of our speakers. We'll start with Chanel Porcher from Ancient Song Doula Services.
There we go.
Sorry.
There we go. I'll say that again. Good afternoon, everyone, to the members of the Black Maternal Health Caucus. My name is Chanel Porcher Albert, and I am the founder and executive director of Ancient Song Doula Services. Ancient Song is a community-based doula organization working to reduce racial disparities and iniquities within reproductive health care. We have provided approximately over 1,200 plus services to New York City parents with personalized, comprehensive, culturally relevant care. Trained and certified thousands of doulas nationally and demanded justice for Black women and families, and spearheaded the fight against racial disparities in maternal mortality and morbidity since its founding in 2008. Ancient Song is a vital community entity and a leading voice in underserved Black women, pregnant people, women of color, and marginalized communities within New York City. We do this by providing full spectrum doula services, which means that we offer abortion, adoption, birth, postpartum, miscarriage, and stillbirth services. Training and certification, conferences, and educational forums to address maternal mortality and severe maternal morbidity, implicit bias, and racism within healthcare services. Over the past few years, doulas have become key players in the fight to end racial disparities within the maternal mortality and morbidity. Doulas perform emotional and physical support in a non-clinical and non-medical fashion for pregnant and birthing persons and their families. We employ client-centered models of care, meaning that our sole purpose is to place our clients' needs first and be their advocates when they cannot themselves. As many studies have suggested, doula care is associated with fewer medical interventions during labor and delivery, such as epidurals and cesareans, shorter labors, positive birth outcomes, and increased breastfeeding initiation and duration. Therefore, many states have passed legislation expanding access to doula care services for marginalized and low-income persons. While this legislation is critical in widening lens of access to proper pregnancy and birth support, few outside of the birthing community fully understand the differences between the types of doulas and their scopes of practice. All doula care is valuable, but community-based doulas have been proven to help to reduce racial disparities in maternal and birth outcomes. Community-based organizations such as Ancient Song provide culturally relevant care that advocates for informed consent and addresses racial discrimination, implicit bias within communities of color, and marginalized communities. In order to help expecting parents navigate social challenges and attain positive maternal health outcomes, community-based doulas deliver comprehensive, holistic care. We work tirelessly to ensure that each and every person has a positive parenting experience, regardless of their race, gender, zip code, and socioeconomic status. Although community-based doulas are not new to the conversation surrounding race-based maternal health disparities, the legislation around them is very green. Bills such as the Maternal Care Act of 2018 and Mommy's Act of 2018 and the Mama's First Act of 2019 demand that doula care is recognized as a viable healthcare option. Yet barriers to both the doula profession and access to care for families have not reached an equitable solution. Please consider our recommendations as follows. Fund Black women-led birth worker organizations. Community-based doulas must be paid a living wage and a reasonable amount for services provided. CBO programs offer doula support at no or low cost to low-income birthing persons and deserve to be compensated because they themselves are often too low income. To successfully reduce racial disparities in maternal health outcomes, federal Medicaid coverage of doula services must acknowledge community-based doula organizations as certifying agencies so trainees can benefit from participation in Medicaid and health insurance programs, and women and pregnant people can benefit from holistic care they provide. Support the expansion of existing community-based programs, including those led by women of color, that provide culturally relevant, trauma-informed, comprehensive support to low-income communities of color. And pilot programs in areas with the worst maternal health outcomes and the greatest racial disparities and the most need. Legislation must include input from birth workers and community stakeholders who are the experts within their care. Measures must be taken to address the root causes of structural and institutional racism in our healthcare systems beyond expanding access to doula care, such as midwifery access. Measures must be also taken to address accountability mechanisms for consumer self-reporting and providing reporting that can inform institutional policy and reform that centers the patient and addresses a human rights framework within the reproductive health care services. Racialized perceptions of Black women infiltrate every single system in our country, especially healthcare. Doula care provides care that the medical system does not, but racism impact on Black women's bodies starts before they consult with a doula. Addressing racial disparities in maternal health outcomes requires us to challenge and transform our healthcare and our systems. Expanding doula care access is only one facet of the movement to break down a system shaped from white male experiences so that we may build a new one that reflects racial and gender parity. I thank you very much for the opportunity to speak.
Thank you, Chanel. Next, we'll hear from Ebony Marcel from March for Moms.
Good morning, everybody. Or wait, is it afternoon? I'm sorry. Thank you, Representative Adams, Underwood, and members of the Black Maternal Health Caucus and staff. Thank you for your leadership and for this opportunity to share my work. My name is Ebony Marcel, and I'm the Director of Midwifery at Community of Hope here in DC, and I care for predominantly Black women, predominantly Medicaid, and I'm the founding board member for March for Moms. March for Moms is a nonpartisan, solution-oriented 501c3 nonprofit that advocates for the best possible health and well-being of all mothers. For 3 years, we have organized a rally on the National Mall to share the experiences and ideas of extraordinary people working to produce a safer and more equitable American maternal health system. Our goal is to highlight solutions that will end maternal mortality, improve access to high quality and equitable care, and broaden support for the challenges of early parenting. Beyond the rally, March for Moms works across a broad coalition of consumer and family professional policymakers and industry representatives to align and amplify advocacy strategies and policy goals to ensure that every American family can grow with dignity. As a policy-focused consumer organization, we advocate for 3 intersectional policy priority areas for your consideration. First, given the demonstrated impact that coverage and access has on maternal health outcomes for Black women, Medicaid reform. Every day, I see the difference that extending Medicaid eligibility to all women to a year postpartum would make, as well as Medicaid financing changes to ensure that states can pay for more supportive, community-based services for families in the prenatal and postpartum period. Second, and related, particularly for Black women, supporting and scaling evidence-based, integrated, community-led care models like the one I practice in, predominantly using the midwifery model of care with seamless coordination to primary care, OBGYN specialists, and integrated behavioral health. We need Medicaid and commercial payers alike to use value-based payment models that are appropriately risk-adjusted to allow us to provide comprehensive services across social, medical, and behavioral needs for moms at a scale and not just as grant-funded pilots. Lastly, mandatory paid leave up to 6 months postpartum for both parents that ensures family economic empowerment and well-being at this vulnerable time in life. We look forward to working with all organizations in this room to develop an aligned policy agenda that is centered on the experiences of Black moms and families across the United States of America. We are happy to be a resource to you, the caucus, your staff, and to continue to explore solutions to this issue that sits at the heart as who we are as a country and a society. Thank you.
Thank you, Ebony. Next, we'll hear from Nia Michelle of the National Birth Equity Collaborative.
Good afternoon, and thank you, Representatives Adams and Underwood, for leading the charge for Black mothers in this country. I am Nia Mitchell, and I am here representing the National Birth Equity Collaborative, where we create solutions that optimize Black maternal and infant health through training, policy, advocacy, research, and community-centered collaboration. We have also worked with Indigenous and rural communities around improving birth outcomes for mothers and babies. We know that when you center those most impacted and tailor your solutions to meet the needs of local community members, improvements for all living within the community happen. Our founder and president, Dr. Joya Creer-Perry, is a longtime member of the National Medical Association, American College of OBGYN, and the American Medical Association, and knows the importance of providers in the improvements that must occur so that the United States is no longer the worst performing industrialized nation when it comes to maternal health. But she also works really hard to ensure that we all recognize that the solutions do not lie within those organizations alone. In fact, healthcare, insurance companies, large legacy nonprofits, and public health must step back and follow the lead of Black women-led organizations across the nation for answers to this crisis. The traditional responses, such as getting longer-acting birth control, getting prenatal care, or smoking cessation, have not ever closed the gap for Black mothers and babies. Blaming and shaming Black women and birthing people around childbirth not only causes mental stress and trauma, it causes women like Dr. Siobhan Irving, a health disparities researcher at the Centers for Disease Control and Prevention, to not be seen as fully human and therefore to die from treatable causes. It is this knowledge that race is a social and political construct that causes a hierarchy of human value based upon skin color, that has caused policymakers who sit in the same seats you currently occupy and pass legislation that blocks access to insurance, care, equal pay, paid leave, and lower funding for Medicaid reimbursements. This list can go on and still continues today. However, with the creation of the Black Maternal Health Caucus, we have a renewed opportunity to get it right. We strongly recommend the utilization of the Black Mama Matters Alliance's policy agenda as a guidepost to ensure all legislation you support puts the assurances in place for Black women and birthing individuals to thrive before, during, and after pregnancy. 50% of births in this country are covered by Medicaid. When we decide not to invest in Medicaid, we are saying that those mamas don't matter. 60% of maternal deaths occur postpartum. When we say that there is no need for paid leave, equal pay, or insurance coverage after 42 days, we are saying those mamas don't matter. Women across socioeconomic statuses are telling us that their providers are not listening to them and not explaining to them what is happening in childbirth. When we have no mechanism, to require providers to learn cultural humility and to be held accountable when they are disrespectful, we are saying those mamas don't matter. Thank you for taking this step to end the devaluation of Black women, Black birthing people, and Black motherhood.
Thank you, Nia. Next, we have Danielle Rodriguez from Sister Song.
Good afternoon, and thank you for including Black-led orgs to the conversation around what is not only affecting our community, but also ourselves. We are not exempt from this crisis as our lives are in danger too. Again, my name is Danielle Rodriguez, and I'm here as a birth worker based in the South and representing Sister Song, the National Women of Color Reproductive Justice Collective. We are a Southern-based national organization, and for over 20 years, we have worked to amplify the voices, experiences, and leadership of Indigenous, Black, and women of color in order to achieve reproductive justice by dismantling white supremacy and securing human rights. Since the release of our shadow report submitted before the Committee on the Elimination of Racial Discrimination entitled Reproductive Injustice, Racial and Gender Discrimination in U.S. Healthcare, co-authored by the Center for Reproductive Rights and National Latina Institute for Reproductive Health, Sister Song has been moving material health and birth justice work to the center of the fight for reproductive justice by raising awareness of the rising rates of maternal mortality for Black women. This is exactly what the 12 Black women who came together now 25 years ago to create reproductive justice intended to create, an intersectional movement for our reproductive lives that was rooted in human rights since the launch of this report. Sister Song supports the development of the Black Mamas Matter Alliance as a direct response to the maternal mortality crisis. We serve as the anchor organization for the Alliance, and our executive director, Monica Simpson, is a founding advisory committee member. We are fully committed to the policy recommendations outlined by the Black Mamas Matter Alliance and believe that they should serve as a foundation for this caucus. As a national trainer, we believe that there should be a deeper investment in training and the development of new curriculum and continued education for medical students and service providers that is rooted in the reproductive justice framework. Overwhelmingly, we saw through our community-based participatory research that despite income or education, Black women were consistently treated different and not given access to information. This lack of care inevitably leads to poor health outcomes. We also feel it's important for elected officials to be trained in the reproductive justice framework in order to help strengthen current and future policy recommendations. Thank you so much for this opportunity to share about our work and uplift our recommendations. We look forward to working with you on supporting Black mamas across the country and encourage you to trust Black women. Thank you.
Thank you, Danielle. Next, we have Ruth Coast from the Center for Law and Social Policy.
Great. Thank you. First, before I want to get started, thank you, Representatives Underwood and Adams, and your leadership in the Black maternal health space. Good afternoon, everybody. My name is Ruth Cosi, and I'm a policy analyst on the Child Care and Early Education team here at the Center for Law and Social Policy, also known in CLASS, based here in D.C. CLASS is a national, nonpartisan, anti-poverty nonprofit advancing policy solutions for people with low incomes. We develop and advocate for federal, state, and local policies to strengthen families and create pathways to education and work. Through our strategies, we work to reduce poverty, promote economic opportunity, and address barriers faced by people of color. CLASS focuses on a wide range of issue areas such as child care and early education, youth policy, job quality, income and work supports, post-secondary education, immigration, and cross-cutting issues like racial equity, criminal justice, and mental health. An essential component we must address in the Black maternal health space is maternal mental health. Through our research, connection with partners, and data gathered, we understand that mental health, systemic racism, and poverty are key parts of the Black maternal health crisis. Through our Moving on Maternal Depression initiative, also known as MOMD, which began around the fall of last year, CLASS was collaborating with 10 states to advance policies that improve maternal depression prevention, screening, and treatment among mothers with young children. The 10 states we are working with through this initiative are New York, New Jersey, Pennsylvania, D.C., Louisiana, Massachusetts, Michigan, Oregon, Rhode Island, and Virginia. Working across sectors, we place an emphasis on helping states advance and embed racial equity and culturally relevant services and practices into policy and systems change. Integrating racial equity and acknowledging the racial impact of policy and practice decisions on Black women and families cannot be ignored. According to data from the 2015 National Survey on Drug Use and Health, Half of all Black mothers who've experienced a major depressive episode live in poverty, compared to 1 in 4 white mothers and 1 in 3 Hispanic mothers. As highlighted by the statistic, addressing the needs of Black women and Black mothers is a immediate concern. Here are a few recommendations we would like the caucus to focus on. First, in any conversation around maternal health, mental health needs to be talked about and integrated. As you develop policies, please ensure that the voices and experiences of Black mothers who experience mental health conditions are part of the creation of these policies. Number 3, we need to think beyond medical models to ensure legislation and conversation includes culturally relevant services and funding streams. And lastly, mental health services are underfunded. We must ensure that funding meets the needs of Black mothers. For recommendations for the members of Congress, we first know that everyone's here today because you want to improve Black maternal health outcomes. We want to ensure other members of Congress understand the disparities in access to care and Black maternal mental health in the context of Black maternal health. Different cultures define mental health differently, and it is important that we acknowledge that when we assess mental health concerns across various racial ethnic groups. Some prefer asset-based language, focusing more so on wellness and self-care rather than terms like depression. The current mental health system does not work to address stigma. It is important to consider the role that stigma plays in the ways to eradicate stigma as we work to improve access to care. Thank you very much.
Thank you. Next, we have Kirsten Stewart from Futures Without Violence.
Thank you so much. Futures Without Violence, for those of you who don't know, is a national nonprofit organization dedicated to ending violence against women and children. We base our work in a public health and social justice lens, and we also house the National Health Resource Center on Domestic Violence. I also would like to thank you all for the opportunity to be here, in particular to the Congresswomen for launching this incredibly important caucus. We also want to add our support to the suggestions we've already heard from so many of the speakers here, and the need to ground everything that we do through policy in a deeper understanding of structural racism and its impact on maternal and infant health. I would like to add for your consideration 2 other issues: the role of domestic violence and sexual assault on these disparities. Domestic violence has both direct and indirect effects on maternal and infant health. First, homicide and violence during pregnancy harm and in some cases kill women, and they kill Black women at disproportionate rates. Black women experience higher rates of intimate partner violence. In fact, more than 40% of Black women have experienced physical violence from a partner. Often this violence is concentrated in young adulthood, times of greatest risk and likelihood for pregnancy as well. By race and ethnicity, non-Hispanic Black women are also most likely to die by homicide than any other women, with more than half of those homicides being related to intimate partner violence. And in some cases, the pregnancy itself may be a motivating factor in the violence. Black women are not as safe as white women and other women in this country, and so we must address issues of domestic violence, and we must address those by supporting organizations that are led by and support Black women in particular. In addition, what we often see is that Black women are actually criminalized for their efforts at survival. In trying to protect themselves, they are far more likely to go to jail, they are far more likely to be incarcerated for minor offenses, and things like running away from trafficking, right? Black women are disproportionately affected by sexual violence as well, and then as they try to survive, they and their children are often criminalized. In addition, violence has significant health consequences beyond those directly mentioned. We've already heard about the need to address mental health and substance use and address the stigma that often goes with those or blames women for their own victimization. We also are beginning to understand more deeply the impacts of trauma and historical trauma and violence across the lifespan on Black women's health and maternal health more generally. As I think someone said earlier, our solutions have to begin before women are pregnant. The toll of violence and trauma on the body begins much younger. Black women Native women as well, also experience sexual violence at much higher rates. And again, particularly sexual violence in childhood. We don't have as strong a data because the stigma is so great, and frankly, because we haven't cared enough to ask the questions. And so we need to do a better job of both gathering that data, understanding its implications, but then also not making disclosure of deeply traumatic and personal events a condition for getting help. No one needs to know what happened to you when you were 8 years old to give you information and resources and warm referrals to anti-violence organizations that can support you in your healing. And we like to say it is not just about healing, it is about thriving. Again, like racism, intimate partner violence contributes to late entry into prenatal care, many of the health consequences that we've already heard. So I won't repeat those. But I do want to then jump, if possible, to the recommendations, because I think that's what we've been called upon most directly to offer. First, the Family Violence Prevention and Services Act is up for reauthorization this year. There is proposals to include culturally specific programs, and we need Congress and would ask the members to support inclusion of the culturally specific set aside within FIPSA in the reauthorization. In addition, there's funding for health programs, and we would see this as either supporting increased funding for those health programs, or in terms of we recommend creating a specific program that looks directly at the intersections of these issues. The Violence Against Women Act does include a health section. It is less well known. We continue to try to push the non-criminal justice sections of the Violence Against Women Act, and would call on Congress and ask for this caucus's support in funding for the health programs, and specifically some of the new recommendations in VAWA address two-generation solutions that look at early childhood and maternal and infant health. Increase support from the maternal and child health programs, some of which you've already heard identified. Increase the support for work at HRSA. HRSA has an intimate partner violence strategy. It is not funded. There is a small program for, it's right now a few $100,000 that's looking at work with community health centers to help them address the impacts of violence and trafficking on health, and we would encourage continuation and increased support for that program. It was included in the House's Labor H bill, so we hope it will stay in there in whatever final negotiations are made. And then finally, we do need additional research that looks at these issues, as others have said, in this intersectional way, and the relationship between violence, historical violence and trauma, its impact on the health, and just the impact of violence on women's bodies. If we look at pregnancy as the ultimate stress test on a body, we know that this that the trauma is weighing on women's bodies, and they're not getting the help and support that they need, and it is disproportionately affecting Black women. And we need that research to help make the case, and we continue to hear from NIH that we either never have the sample size that's big enough to tell us anything conclusive, or we're just cutting funding for IPV generally, and that needs to stop. Thank you.
Thank you, Kirsten. Next, we have Nan Strauss of Every Mother Counts.
Good afternoon. Thank you to Congresswomen Adams and Underwood and the Black Maternal Health Caucus for hosting this summit. It's an honor to be here to stand alongside the Black women-led organizations that are spearheading this critical work, and to have the opportunity to share our recommendations. I'm Nan Strauss, the Director of Policy and Advocacy at Every Mother Counts. Every Mother Counts is a mission is to make pregnancy and childbirth safe for every mother everywhere. And in the U.S., this means making equity for Black women a top priority. We work towards quality, respectful, and equitable maternity care for all by raising awareness, by investing in community-based solutions, and by mobilizing communities to take action for change. We prioritize working with community-based partners, our other organizations bringing the voices of Black women and women of color to the forefront. Our top recommendation today is to move from research to action, to make changes now. For too long, we've focused on studying maternal deaths and disparities, even as deaths rise and disparities persist. To achieve meaningful, durable change, we need to think bigger. We have to shift our attention from rescue to prevention, expand our vision from a narrow clinical view to a broader holistic approach. And we already know more than enough about what works. We urge the caucus to help scale up proven models like midwife-led clinical care and perinatal support provided by doulas. Both models improve outcomes and the experience of care, both reduce cesareans and preterm births, increase breastfeeding, improve care satisfaction, and prioritize shared decision-making, communication, and building trusting relationships. And they're cost-effective. Yet these evidence-based solutions have been out of reach for many communities, especially those that would benefit the most. We recommend expanding access to a diverse workforce of midwives and doulas, and reimbursing midwifery and doula care at reasonable and equitable rates. We also recommend advancing the bills proposed by members of this caucus. The Healthy Mommies Act, Maternal Care Act, and Mamas Act would all improve Black maternal health by extending Medicaid coverage to a full year following childbirth, enhancing available support services, addressing racial bias head-on, and filling gaps in our fragmented system. As Amnesty International found nearly a decade ago, poor outcomes and extreme racial disparities in the U.S. reflect a maternal health crisis in this country, and it is a violation of human rights. While deaths and complications are common measures of maternal health, people are more than just their health outcomes, and Black women deserve more than just surviving. The Giving Voice to Mothers survey revealed that 1 in 3 women of color giving birth in a hospital reported mistreatment during their care, including being shouted at, being scolded, ignored, or having requests for help refused or delayed. Repeated news accounts will not let us forget that Black women, healthy, educated, and strong Black women like Shalon Irving, like Kira Johnson, are dying needlessly after their concerns were ignored, their requests for help delayed, and their voices silenced. These stories confirm what we all know. We can't achieve good health outcomes, health equity, and the realization of Black women's human rights until all healthcare providers and all of us listen to Black women, trust Black women, and treat Black women with the respect and dignity that are their right. Thank you.
Next, we'll have Dawn Godbold from the National Partnership for Women and Families.
Thank you. Good morning. And thank you to Representatives Adams and Underwood for their leadership in this space. I'm Dr. Dawn Godbold from the National Partnership for Women and Families. We are a national nonprofit organization that for the last 48 years has advocated on behalf of all women and families in 3 key issue areas that reinforce each other: economic justice, access to reproductive health care, and access to affordable, high-quality health care. Following the lead of several Black women-led organizations, including the Black Mamas Matter Alliance and the National Birth Equity Collaborative, the National Partnership is fully engaged in working to help solve the maternal health crisis. We have interviewed community-based maternal health care models, including Mama Toto Village and Common Sense Childbirth, to help craft a series of policy recommendations. We have interviewed over 2,500 women in our Listening to Mothers in California survey, and we have provided countless hours of technical expertise during the drafting process of maternal health bills. It is disgraceful that in 2019, Black women are dying at such an alarming rate. It is outrageous that so many Black women come close to dying. And it is unacceptable that many of the poor maternal health outcomes that Black women experience are linked to systemic inequality and racism. We know that 60% of mortality cases are preventable. The National Partnership has talked to midwives, doulas, OB-GYNs, and Black mothers. They have told us what they need and what they want to address the maternal health crisis, and I'm here today to advocate on behalf of those women to tell Congress what must be done. I'm not going to go into detail on many of my policy recommendations because they have been in detail gone over, but I will repeat them to amplify. We must address the social determinants of health, particularly alleviating poverty. We must expand pregnancy-related Medicaid coverage past the typical 60 days to at least 1 year, given that 1 in 5 pregnancy-related deaths occur between 43 days and 1 year after giving birth. We must support community-based maternal health care models. These perinatal healthcare professionals are on the ground and they understand the nuances of Black and Brown communities. We know that they provide a high quality of care, they draw power from within the communities, and they have very promising results for addressing maternal mortality. But they need adequate funding and resources to expand their practices. We must support maternal mortality review committees, standardize quality measures and accountability measures, and the data collection process. We need to know why each death occurs, and we need more information so that all women can receive the same quality of care despite their skin color or zip code. We must also require diversity in maternal mortality oversight. These review boards and governing bodies should include people who are from the community, and to be clear, they must include people of color. We also need to address discrimination and racism in the healthcare system. Research shows that Black women receive a lower quality of care and are often subject to discrimination in the healthcare field. We call for better training of medical professionals, and we call for more pathways that create diversity within the medical field. We advocate on behalf of increasing access to paid, job-protected time away from work, that's paid leave and paid sick days, so that women have the time to care for themselves and their families. And we also encourage hospitals and medical practices to participate in quality improvement efforts, including perinatal quality collaboratives. Specifically, we ask Congress to develop, support, and pass legislation that will reduce maternal health disparities. We are currently in support of and have provided technical expertise to most of the following bills. And you'll notice a theme: the Mamas Act, the Moms Act, the Mommies Act, the Healthy Mom Act, the Quality Care for Moms and Babies Act, and the CARE Act. This is the most diverse Congress that the United States has ever seen. With so many women and women from diverse backgrounds serving, we anticipate legislation that is effective and innovative. Black women should not lose their lives or come close to it in an attempt to bring forth life. Thank you.
Thank you. Now we'll hear from KJ Hertz of March of Dimes.
Good afternoon, everyone. My name is KJ Hertz. I'm the Director of Federal Affairs with the March of Dimes. On behalf of the March of Dimes, I'd like to thank Representatives Adams and Underwood for launching the Maternal Black Health Caucus. At the March of Dimes, our mission is to fight for the health of all moms and babies. We are pleased to be among the leaders fighting to end the public health crisis facing Black moms and babies and their babies. And make no mistake, this is a public health crisis that we're facing. Even one maternal death is a tragedy. I know a lot of the statistics have been already mentioned, but they really do bear repeating. The fact that over 700 women die each year in the United States from pregnancy-related causes is truly unacceptable. The fact that Black women are 3 to 4 times as likely as white women to die from pregnancy-related causes is really an emergency that demands immediate attention. Beyond the shocking numbers of deaths, another 50,000 women experience severe complications due to pregnancy that threaten their lives or health. Women of color are most at risk facing life-threatening complications. Our nation must act to immediately address this crisis. Now is a time to raise awareness about how our nation is failing Black mothers, their children, and their families. We must identify the causes of disparities in pregnancy outcomes for women of color and enact policies that eliminate those disparities. March of Dimes supports efforts to eliminate preventable maternal mortality and severe maternal morbidity and the unacceptably large disparity rates experienced by Black women. To that end, our staff and volunteers are working in the legislatures and health agencies across the country to ensure that every state has a robust maternal mortality review committee to gather data to inform state and federal policy change. We must support state perinatal quality collaboratives to actualize MMRC recommendations. March of Dimes champions policies to address provider implicit bias and eliminate systemic barriers in healthcare that perpetuate inequalities in maternal health outcomes. We are developing tools to address the differential care women of color receive. This includes where we're launching an implicit bias training for healthcare providers to help those caring for pregnant women and new mothers provide better care. And we look forward to sharing more details about this exciting new initiative. At the federal level, March of Dimes has worked intensively to support legislation to address maternal mortality head-on. Last year, Congress took an important step towards addressing the nation's crisis by passing the Preventing Maternal Death Act of 2018. This legislation is helping states to support MMRCs to review each instance of maternal death and develop recommendations to prevent them in the future. In FY 2019, Congress took a big step forward by providing $50 million in new funding to support state reviews and other activities to protect the health of pregnant women and new mothers. And as was mentioned earlier today, we commend the efforts by the House in its labor HHS spending bill to add on to this investment in these important programs. And we urge the Senate to follow suit. Congress cannot stop now, though. We know that the causes of maternal mortality and severe maternal morbidity are diverse. They include physical health, mental health, social determinants, and much more. They can be traced back to issues in our healthcare system, including quality of care, systemic problems, and implicit bias. They stem from factors in our homes, our workplaces, and our communities. To support women, to save women's lives, we can't just stop with one bill. Congress must build upon its success last Congress by advancing a comprehensive legislative package this year, or this Congress. There are several good bills that have been mentioned already: the Mamas Act, the Mommies Act, the Maternal Care Act, the Quality Care for Moms and Babies Act, all of which the March of Dimes has endorsed, that would form a sound basis for a comprehensive legislative package and have been introduced by members of this caucus and others. So we support those measures moving forward. In addition to a bill that would directly address maternal mortality, we also can't forget that we have to defend against some of the attacks on women's health that are now going on. This includes threats to the Affordable Care Act, pre-existing condition protections under ACA, essential health benefits including maternal mortality, or rather maternity care, newborn care, mental health services, and some of the critical affordability provisions that were there. It also includes some of the threats to Medicaid through Medicaid waiver proposals, such as work requirements that would set up new barriers for women receiving the care that they need. It also would include such measures as enrollment caps and lockouts and increased cost sharing and premiums. These would all set up new barriers to women receiving the care that they need both before, during, and after pregnancy. And we also must support efforts at the state level to increase care after pregnancy up to 12 months postpartum. The March of Dimes pledges our support to the Maternal Mortality Health Caucus and leading the charge in the United States Congress, and we stand ready to support Congresswoman Adams, Underwood, and the entire caucus in that effort. Thank you very much.
Thank you, KJ. And just a reminder that we're coming up pretty quickly on 1 o'clock here, and so we'll try to keep our remarks to just 3 minutes. Patrick Ross of the Joint Commission we'll hear from next.
I promise I'll try to keep this brief. Thank you, Representative Adams and Underwood. members of the Black Maternal Health Caucus, all of your staff, for inviting the Joint Commission to speak today on what the Joint Commission can contribute to reducing preventable maternal deaths. An independent nonprofit organization, the Joint Commission accredits and/or certifies more than 22,000 U.S. healthcare organizations across the continuum of care, including most of the nation's hospitals. Accreditation is voluntary, though government regulatory bodies, including CMS, recognize and rely upon the Joint Commission's decisions and findings for Medicare or licensure purposes. The Joint Commission is deeply concerned about the rate of pregnancy-related maternal deaths in the U.S. We appreciate that the causes are multifactorial, including social and economic conditions that will require the efforts of many, including most of those around the table, all of those around the table, and many more, to address all of them. However, the Joint Commission believes that it can make a significant difference through its new accreditation standards that address preventable hospital deaths. Sadly, we know that too often a mother's serious conditions, such as preeclampsia or hemorrhage, go unrecognized or untreated in a timely manner, and that hospitals can respond to maternal emergencies more effectively. Furthermore, complications often arise during the early postpartum period after hospital discharge. In April, the Joint Commission proposed new standards that focus on steps hospitals can take to reduce the risk of these complications. They aim to reduce patient harm by targeting maternal hemorrhage and severe hypertension or preeclampsia, some of the leading causes of preventable maternal deaths. For Black mothers, preeclampsia and eclampsia-related deaths are disproportionately common, occurring at more than twice the rate for white women. We've received initial early positive feedback on the proposed standards and expect the finalized standards to be released by January 1, 2020, and go into effect July 1st next year. The standards are modeled after the successes seen by the California Maternal Quality Care Collaborative and were developed in collaboration with the American College of Obstetricians and Gynecologists. Under the new standards, hospitals, among other things, are required to train clinical staff in hemorrhage and preeclampsia treatment procedures, define management practices, including clinical measurement and early identification of patients at risk of hemorrhage or severe hypertension before and after delivery, provide immediately available emergency medication and supplies in the obstetrics unit, develop multidisciplinary response teams and guidance as to when to transfer the mother to higher levels of care, conduct preparedness drills, discuss when to schedule follow-up appointments with patients, and provide patient education on the signs and symptoms of severe maternal complications in the hospital and after discharge that require immediate care. Because our standards apply to roughly 80% of U.S. hospitals and over 90% of hospital beds in the country, adherence to the new standards should have a significant national impact. However, about 1,000 hospitals are not accredited by the Joint Commission and instead rely on either other accrediting organizations or on direct certification through CMS. We suggest the Black Maternal Health Caucus encourage all hospitals to follow or develop similar standards to those proposed by the Joint Commission and to share best practices to improve the quality of health care mothers receive during pregnancy, delivery, and postpartum. Thank you.
Thank you. Next, we'll hear from Dr. Eileen Sullivan-Marks of the American Academy of Nursing.
Thank you. I'm Eileen Sullivan-Marks, a nurse, and in addition to being president-elect of the American Academy of Nursing, I'm dean of a college of nursing at New York University, and the concept of how I prepare the next generation is very close to my everyday life. Thank you, Representative Adams, Representative Underwood, and the entire Black Maternal Health Caucus for inviting me to speak on behalf of the American Academy of Nursing at the Stakeholder Summit. The Academy, who are we? We're more than 2,600 fellows who are nursing's accomplished leaders in education, management, practice, research, and policy who've been recognized for extraordinary contributions. The Academy stands in support of the Black Maternal Health Caucus, and we're ready to work with you in Congress to examine the causes and consequences of maternal mortality and morbidity and how such causes and consequences are exacerbated by, as we heard, inequitable access to care and inconsistent quality of care. And we're committed to these as part of our foundational support. But as I've listened today, I think, yes, we are doing a lot with thinking about implicit bias. We're doing a lot. But one of the things that we have to do as healthcare professionals is recognize that we failed, that the healthcare professionals have failed in this effort. We have not listened. We have not really been open in a systemic and institutional way, in an educational way. And so I hear that, and I will take that on, as I am president of the American Academy of Nursing. As one of our 3 policy priorities this Congress, we recognize that we must closely consider the social determinants of health and expand access to quality care to improve health. We have expert panels that enable our fellows to apply their expertise to advance evidence-based innovations in healthcare delivery. Our Academy's Maternal and Infant Health Expert Panel recently published a policy brief on African American mothers' persistent excessive maternal death rates and has called for the collection of more comprehensive and consistent data on African American mothers across all states, as well as additional funding to make this possible. Second, for equitable healthcare insurance coverage and access to care for all women and mothers, especially during the childbearing period, the requirement of coterminous mortality and morbidity review boards in all states with county-level data on pregnancy mortality available to the public, and finally, the appointment of a special task force by the CDC to launch a sustained media campaign on prenatal pregnancy and postpartum care of mothers. I would like to recognize the Academy has 2 edge-runner models that directly address maternal care. And these are innovative nurse-designed models of care that have been operating for decades, and we need to scale up such models, as we've heard before. Both of these programs have proven effective. First, the 11th Street Family Health Services at Drexel University has reduced preterm births to 2.4% in Black patients compared to 15.6% in Philadelphia broadly. Secondly, the Family Health and Birth Center in the Developing Family Center here in D.C. provides midwifery and nurse practitioner model for cost-effective maternal care. After 6 years, the center demonstrated a substantial lowering of preterm birth, low birth weight, and cesarean section rates, which are, as we all know, well beyond what any of us want to see. Both of these innovative models address the issue of how to hear the community, work with the community, and give voice to mothers and families. I'm honored to be included in this important discussion and offer the Academy and its fellows as resources in addressing these important issues. Thank you for your efforts to reduce maternal mortality and morbidity, especially among Black mothers, and for your work to eliminate health disparities while promoting equitable care. Thank you.
Thank you. Next, we'll hear from Jacqueline Richnovsky from the Association of Women's Health, Obstetric, and Neonatal Nurses.
Thank you. Good afternoon, Congresswoman Underwood, Congresswoman Adams, members of the Black Maternal Health Caucus, and fellow stakeholders. Thank you for allowing me to present my remarks today. I am Dr. Jacqueline Richnovsky, the Vice President of Research, Policy, and Strategic Initiatives at the Association of Women's Health, Obstetric, and Neonatal Nurses, and I am a nurse. A1 supports nurses caring for women, newborns, and their families through research, education, and advocacy. To those ends, we publish a research journal, a practice journal, practice guidelines, practice briefs, and position statements on issues important to our members. We also produce education and training programs to prepare nurses to practice in both low and high-risk critical care obstetric and newborn settings. As you know, nurses make up the largest profession in the healthcare workforce. They also spend the most time with patients of any healthcare worker. To reduce disparity in maternal mortality, nurses must be part of the solution. Nurses are positioned to provide unique insights into patient care circumstances that contribute to women's deaths. Of particular concern to A1 is the rise in post-birth deaths in Black women, because many of the risk factors for complications associated with severe maternal illness and death may not clearly be identified before hospital discharge. By improving post-birth education, nurses are poised to help all women know how to recognize and respond to potentially life-threatening warning signs. And please grab on your way out a Save Your Life handout, which is our primary patient education tool for this. Efforts must be put towards allowing nurses to have ample time after delivery, but before the woman's hospital discharge, to provide necessary education and teaching to new parents. Efforts are underway to revise A1's 2009 staffing guidelines with plans to transition to evidence-based staffing standards, which will ensure the safest possible environment for both mom and baby. Nurses must be available at the bedside, providing uninterrupted care to the mother during this vulnerable and risky time. A1 is beginning to work on a 2-year project to address issues of implicit bias in the way maternal health care is provided. We have taken steps to ensure that effects on racism on maternal health outcomes is incorporated into A1's educational resources for our post-birth warning signs program. This project will include a stakeholder meeting of select patient advocacy organizations and Black women and their family members who have experienced a loss or who have survived severe maternal morbidity to provide input to help guide A1's future work. As a grant funder of research into evidence-based practice, A1 has recently funded research to continue to elucidate the causes of racial disparity in maternal mortality. Recent research has included projects such as the lived experience of Haitian immigrant women in postpartum depression, and another titled Reducing Disparities in Postpartum Care Utilization, development of a clinical risk assessment tool. A1 is a member of the Coalition for Optimal and Equitable Maternal Health and a member of the Coalition's Blueprint Working Group. We are also a longstanding member of the March of Dimes Prematurity Collaborative, and we serve on the executive committee of HRSA's AIM project. The racial disparities in maternal mortality have been a feature topic on the last 2 A1 national conventions. Both years, panels of experts discussed this topic in sessions attended by hundreds and live streamed to thousands. A1 recommends the caucus focus on the following policies: support and fund training programs to address implicit bias among clinicians and encourage integrated healthcare services that honor the strength of culture and support of pregnant women in evidence-based care. Support Medicaid expansion in whatever way possible to increase coverage from 60 days to 1 year postpartum. Prioritize the highest possible funding level for programs that seek to prevent maternal deaths and eliminate disparities in maternal health care outcomes. We've mentioned many of them, and for the sake of time, I think you all know them well. Support childbirth education and doula services, which contribute to the woman's preparation for and support during childbirth as a covered health benefit in both public and private health insurance plans. We know that the caucus understands that the racial disparity in maternal mortality is a multifactorial problem and that there is no single policy that will close the disparity gap. There is much work to be done to understand all of the causes. A1 continues to research and develop guidelines and education for the nursing workforce so that every woman has a healthy birth. Thank you for the invitation to meet with the caucus today.
Thank you. Dr. Patrice Harris of the American Medical Association.
Well, good afternoon, and let me add my thanks to Congresswomen Underwood and Adams for bringing us here today. The American Medical Association commends you for bringing all of us stakeholders together for this summit. My name is Dr. Patrice Harris, and I am the president of the AMA. I am a practicing child and adolescent psychiatrist from Atlanta, so I appreciate the earlier mentions regarding the importance of addressing mental health as a critical component of overall health. And certainly we need to make sure that we address early childhood mental health, which is really about socio-emotional development. So that's a critical piece of this as well. The AMA's strategic and focused approach to health equity includes addressing many of the issues that are leading to where we are today regarding the unacceptably high rates of maternal mortality and morbidity in Black women. We, as many have said, understand there are multiple factors that contribute, but it is important sometimes to just highlight those, that name those, as someone said earlier today. And so it is lack of insurance, or inadequate coverage in all the periods prior to, during, and after pregnancy. It is closure of rural and urban maternity units. It is lack of interprofessional teams trained in best practices. It is structural determinants of health, such as public policies, laws, and racism that then produce inequities in the social determinants of health. And finally, it is stress exacerbated by discrimination that can worsen high blood pressure, heart disease, and diabetes during pregnancy. So our approach, the AMA approach to address this issue and many issues regarding health inequities are as follows. First, an explicit focus on communities of color. We have to address the inequities in all communities, but part of our work will be an explicit focus on communities of color. Next is ensuring a more diverse physician workforce. We also have to continue to partner with organizations, many in this room, which are already leading the charge to ensure that all women have safe and healthy pregnancies, deliveries, and postpartum care, and educating physicians and medical students on the structural and social determinants of health. In fact, this fall, as part of AMA's Accelerating Change in Medical Education Initiative, hundreds of future physicians beginning medical school will participate in a new curriculum. And part of that curriculum will be training and understanding the impact of social determinants on health. Recently, the AMA created the Center for Health Equity. That's being led by our first Chief Health Equity Officer, Dr. Aletha Maybank. And our work will embed health equity across the AMA and will become part of our practice, process, action, innovation, and organizational performance and outcomes. So in closing, I want to note that the AMA supported the Preventing Maternal Deaths Act. Others have mentioned that, and that was enacted last year, establishing the maternal mortality review committees. That's a critical first step in efforts to make pregnancy safer, but we want Congress to consider more robust funding and continued funding for that effort. Others have mentioned the Mamas Act. We certainly have to make sure that we continue to support our safety net programs and Medicaid expansion programs, and others have also mentioned the importance of research, but certainly with the lens on cultural humility. So again, it's a pleasure to be here this morning and afternoon, and the AMA looks forward to continued discussion and partnership on ways to improve maternal health and advance health equity.
Thank you, Dr. Harris. Next, we have Sharu Sase-Tufor from the American College of Nurse Midwives.
There we go. It's almost the end of the day, right? Good afternoon. I am Dr. Sherry Sase-Tufor, CEO for the American College of Nurse Midwives. On behalf of ACNM, we thank Representatives Adams, Underwood, and also the caucus for including us in this important conversation to talk about the culture of health for Black women and individuals by increasing access to the midwifery model of care and increasing racial and ethnic representation within the midwifery workforce. While CNMs, certified nurse midwives, and CMs, certified midwives, are well known for attending births, over 50% identify reproductive health and over 35% identify primary care as their main responsibilities. So in my short minutes, and recognizing that disparities exist in maternal mortality, especially for Black women, and also that the midwifery model of care remains drastically underutilized in the U.S. healthcare system, I want to highlight one key legislative effort on our policy agenda, and that is increasing the midwifery workforce. We know that the number of births is continuing to grow and projected to be more than 4.4 million by 2050. And this demand tells us one thing, that we need more maternity care providers, including more access to certified nurse midwives and certified midwives. So we have identified direct funding for midwifery education as the #1 priority. One step that the House has taken is passing legislation that would increase federal funding to accredited midwifery education programs in fiscal year 20. Last month, the House passed this bill, in addition to increased funding for Title VIII nursing workforce development program levels that currently help fund nurse midwifery education programs and also fund fund student nurse midwives. This bill includes a provision which kindly appropriated $2.5 million in funding for fiscal year 20 under Title VII scholarships for disadvantaged student programs. So this means that both certified nurse midwives and certified midwives can apply for direct funding under the Disadvantaged Students Program, thereby helping to increase racial and ethnic diversity within the midwifery community. The inclusion of the provision within the House bill represents a significant accomplishment in raising the awareness of policymakers around the benefits of investing in the midwifery model of care. And we thank you and your colleagues for helping to pass H.R. 2740. One additional item that I would like to mention here today are efforts to help grow the midwifery pipeline and a yet-to-be-introduced legislation known as the Midwives for Maximizing Optimal Maternity Services Act, which is currently under development and pending introduction by Representatives Lucille Roybal-Allard and Jamie Herrera-Butler. This legislation will support our clinical preceptors and also designate funding to increase the number of racial and ethnic students within midwifery programs. We know that patients respond to medical treatment plans at a higher degree with providers of the same race or ethnicity. So this legislation takes deliberate steps to help us achieve this. And finally, we stand ready to work with each of you as we improve the culture of health for Black women and individuals, and we bring about positive change in our country's healthcare system. And we also welcome support from the caucus and co-sponsorship of this legislation when it is approved. Thank you for having us here today.
Thank you. Next is Virginia Andrews from the Society for Maternal Fetal Medicine.
Thank you. On behalf of the Society for Maternal Fetal Medicine, I'd first like to thank the Black Maternal Health Caucus and Congresswomen Adams and Underwood for hosting today's summit and inviting us to participate. SMFM is a nonprofit association representing more than 4,000 individual members, most of whom are MFM subspecialties.